Okay, we're back. I just want to make sure that we were using the best network so you guys wouldn't have any connection glitches. Okay? All right, so yes, last week we looked at lateral thigh pain, and we also talked about the hip compaction as we work on the, other areas of the hip, the lateral, the, medial, the front of the hip, the back of the hip. Hip compaction is still going to be a big one. We talked about how important it is to stay hydrated so your hip joint has a nice fluid cushion, because your body will steal water from the hip when it needs it for other purposes, like keeping the blood volume up, or dealing with inflammation or swelling. It's going to rob water from the joints for that. So keep that hip joint hydrated. And we talked about how the ball and socket can get jammed in, and we did a simple correction where we did the origin insertion treatment. So as we've been talking about, a really good trigger point therapist will not just treat the belly of the muscle, but they'll treat the origin and the insertion. And we talked about how uniquely important that is in the case of hip compaction, because the Golgi tendon organs are at that origin insertion, and they can, like a light switch, shut that muscle right off. The unconscious portion of muscle control will just shut off, and that muscle will feel very weak. In fact, the whole hip will feel weak, and there's all sorts of problems that in the knees and the back, and that can result from a hip compaction where the hip is weak, except for one muscle that's excruciatingly tight. We work on the origin insertion of that excruciatingly tight muscle. In our patient's case last week, it was the glute medius, and these are the results that you get. Why don't you tell us, Linda, would you mind telling us about how you've been feeling since we worked on the origin insertion of your glute medius?
Amazing difference going up and down stairs, being able to get my pants on and off.
What, you couldn't get your pants on when you were sitting?
I had to lift my leg to get it in.
You had to use your hands to get your pants on. Now the leg comes right up.
Yeah, amazing. I've just been doing it habitually for so long, it was like, oh, I don't need to do this anymore.
Yeah.
So difference between night and day.
Yeah. And that's the neurology that you guys are affecting, which is so incredible. So that's great. So we're going to continue onward working on our hip. And our master teacher for tonight to teach us Pain Key 22, Sharon Sauer.
So today we're doing anterior thigh pain, and pain that goes down to the knee, and pain that goes all over the hip and leg too as well, but the main focus is on the anterior thigh today. So that's here, Pain Key 22.
That's right.
Okay, so guess what we're going to do? So we're going to do one muscle at a time today. So we're going to look at everything for one muscle at a time.
Excellent.
So it's a little
What do you mean
different.
by everything?
Well, everything. We're going to do the nerve root.
Yeah.
We're going to do the range of motion test.
Yeah.
We're going to do the treatment,
Yep.
both the if I treated you and if you treated yourself.
Yep.
And then we're going to do the range of the exercise, range of motion
Strength
exercises.
test. Oh, the range of motion exercise, great. Yep.
And the strength test right after. Yeah. So it's strength test in the middle there.
And referred pain. We'll look at that too. So we're going to do
look at the
everything once.
Yes.
Yeah.
The referred pain right after.
And
So
remember, most of that's just found right on this sheet.
it is. It is.
And there it is, right there.
Yeah. It's found all there. This is the Rosetta Stone, myofascial pain and dysfunction. And you could get it from our website.
Yeah, just go to myopain.com, download it under the Bodyworkers Mastercourse tab.
But to get a really good copy, you'll have to go to probably a Kinko's or some kind of store.
Yeah, print it out. This is an 11 by 17.
Yeah.
That's the largest piece of paper. It's really cheap. Print out for just a few dollars.
Okay, so the most likely muscle to cause pain in the anterior thigh is the adductor longus and brevis. That's the most likely one. And it'll be innervated by L2 through L4. And we will do the range of motion test 43.
Okay, fantastic.
Okay, so that's so we'll take a look at the range of motion test 43.
Okay,
Yeah,
all
let's
right.
go ahead and take a look at
Number 43 is a simple stretching of the adductors outward.
So that's the adductors test, so we call that the figure 4 test position, and then the straight leg position. So we can do both of those, yeah.
Should we look at that? Should we have somebody
We
do
can
it?
let's do that. We'll do that. So we can start with the range of motion test.
Okay, great.
Okay, so let's go ahead and let's take a look at the. So this is for our adductors, longus and brevis.
Mm-hmm.
And let's take a look at the range of motion of your adductor. Who would like to first?
All right, we have our willing victim.
I volunteered and she volunteered me also.
So I can observe.
Yes.
what you guys are doing.
Right.
So I get to scream and she doesn't.
So here we have, so we've been heating up her adductor, so that's been good. We're
Yeah.
starting out with heating that up a little bit.
Right. We start with heat always. That makes
And,
your
I'm
job
gonna
a lot
lower the
easier.
table for you just a
Thank
second.
you.
And then I'm just going to give her a little bit of heat underneath her. So I'm going to lower the table down. So after how many years
Going up.
do you decide to get a high-low table? How many years of treating people? After how many years of treating people, when do you decide to get a high-low table?
Let's see. I might have been working 10.
You went
five or 10 years.
5 or 10 years.
I don't remember. It's been so long.
But you deserved it, right?
Yeah. Oh, definitely. Definitely.
Right? Okay.
Probably as soon as you can afford one is the answer.
Hey.
That's true. That's right.
All right. So adductors. This is the range of motion test.
Yes, for this you'll need, if you're going to do this with your partner, a partner, you're going to have a little measuring tape that you'd have with you, and you can see how good you're doing. So you can go like this, and you could see put your foot on your opposite thigh,
Yeah.
and you're going to see how close that comes to the. So you could go to the lateral patella, and you're going to measure to the table. That's -5 inches.
Okay.
That's pretty good. Yeah.
That's pretty good. Yeah.
But yeah, well,
I
that's
happen to
not,
know
yeah.
mine would be worse.
Yeah, so, but it's good if we could keep the opposite
Oh
hip
yeah.
down.
Make sure that
So-
hip doesn't roll.
Yeah, so I'm just gonna go ahead and, it's pretty good anyway. Yeah,
Yeah.
pretty good anyway.
Okay.
This
All
one
right.
is good.
You want to try the other one?
Yes, we would.
See if there's a difference side to side.
Yeah, just gonna check. And here's a little tighter, here's a lateral patella, and it's 7 inches on this side. So remember,
Should it
5 inches right, 7 inches left.
should it
okay?
touch the floor or
No,
table?
no,
or
no,
what
no.
is- What should it do?
Okay, so it could be. We're just going to see how close it gets, how much closer we can make it. You know,
Okay.
but let's take a look at what the past fail here is. We'll take a look at it. Let's go over here. Let's see. So here, no restriction.
No restrictions. 90 degrees from angle of body.
Position what I meant here.
Oh, sorry.
Okay, so here. Well, anyway, if you look at that for a second. Okay, and then we'll see exactly what it is there.
So should her knee be able
I
to
think
touch the table?
I think actually if you put the foot flat like right
Yeah,
here, I
that's
think
another-
actually
Yeah, that's well,
I think at
that's
that
another
point
way.
you're supposed to be able to get to the table.
That's
almost.
another way of doing it
Yeah.
too.
Oh.
So here, I don't like that way, but that's
Yeah.
that's the
It's
way it is.
touching the table, isn't it?
Yeah, it's
Yeah.
pretty good. It's very
very
close.
So here's
Yeah.
so if you put, it's hard to measure when it's pretty close like that.
Yeah. Yeah.
So then you go like this, and that's 4 to 5 inches there. Try it on the other side. We'll do it the same way. So you come this way and come up to about there. Then we'll see on this side, you have the lateral patella,
Yeah.
and that's like 4 inches.
Yeah, not
so
bad.
an inch, that's pretty good. Yes, very
And
good.
what would the referred pain look like if she had
So
trouble
she had
with
the
adductors?
referred pain is all over the front of the thigh. Let's go ahead and look at it. I have it right here.
Oh, you
It's
have
in
it.
front of us right here.
Okay, good.
So it's right here. And it comes all over the front, and then it causes very bad knee pain, and then it causes pain over the tibia.
Uh-huh.
And so a lot of times people they think they have shin splints or something else,
Right.
but it really could be the adductor longus and brevis here, and they could be causing pain up and down, and pretty good knee pain, and all the way down here. But in addition to that, it causes these can cause a lot of other problems with the pelvic
And there's
floor.
adductors. There's 3 of them, right? There's a
Well, you've got the adductors,
So
3,
these are the,
but then you've got the pectineus.
and you have the
fourth adductor.
magnus, right?
Yeah, the magnus. Magnus is
So
on the next
we're talking
page
about
right
trigger
here.
points right up in this region
Yeah,
right there.
yeah. So
Is that
that's
what
right.
caused it? Yeah.
That's right. So we're looking for trigger points right through here,
Okay.
right
Yeah.
here.
Okay. Good.
How does this
Right
impact
there.
the pelvic floor?
Well, the adductors are attaching there, and if they're tight, they distort the pelvic floor and cause a lot of tendinitis right where they're attaching and near where they're attaching.
Would there
So-
be like
Mhm.
pelvic tilt?
Yeah,
could
it
it
could
pull it?
pelvic tilt. Yeah, it could tilt the pelvis forward. Yeah. Okay, so also we're looking for L2 to L4. Okay.
Yep.
As well to see if that might be causing. So something we might do that to look for to see if L2 to L4 might be causing trouble.
Yep.
Is we could actually treat L2 to L4 while we're doing the activity.
Ah.
So say for instance we put like this, and this one was about 5 inches, right? So we could come over here and we could look at L2, and then we'll see if by treating L2 to L4, if it has any impact on the range of motion. If it does, then you know the heightened tone from the vertebrae being slightly closer together because of the multifidus rotatories or other paraspinals might be causing heightened tone in all the muscles distribution.
Right. Yeah. Wow. So the range of motion could get better while you're working on the lumbar spine.
Right.
And
And if
nerve
it
roots.
does, then you know, oh, maybe that has something to do with it.
Yeah.
Okay.
Yeah.
So you're looking at whether or not it does.
Okay.
And so often it does.
Yeah.
So
Cool.
if it does, it's really cool. If it doesn't, that's cool too.
Yeah.
Okay, here, so it improves. So we have it here on top of the leg, like I had it there. And now, instead of 5 inches, it's 3, so improved 2 inches. So
Improved 2
likely
inches.
some of the tension that she might have in this muscle would probably be due to L2 to L4.
And we had actually, Sharon we had talked about that. We helped her with a hip after class last week, and we noticed the same thing, that a lot of problems for her might be coming from that
So
nerve
here
root.
you can feel it has it's a lot of
That
more restricted on
springy
this side.
tension there, yeah.
We measured 7 with
Yeah.
the foot in this
Yeah.
position.
Well, when I had the car accident
Yeah.
12 weeks ago, this knee hit the dashboard harder than this
Oh, well, see,
Ah.
that could have been it. So what Dr. Fisher said, who did a lot of the research for Trevell Simons and a lot of the research that's in their book, and did a lot of the research in general for the field. He was saying how important it was, because if you did injure this, then he said that every time message will go up to the spinal root, and that if you don't look at the spinal root too, you're
Right.
probably missing, a big part of what's going wrong on with that person.
Yeah, because the car hit me on this side, so
Yeah.
this side is tighter.
Yeah,
So
but-
L2 and L4
so-
is where the spinal root is?
yeah. So I'm at that right here, and guess look at
It
it
went
came
down a little.
way
Yeah.
down.
Yeah.
So it's likely that the root has some effect, 50% or more of effect on the range of motion of this adductor here.
Okay.
So,
So
like
it's
I
pretty
said,
good, huh?
Yeah.
what
right.
Master Bodyworker does things like treats on the stretch, treats
Right
the
there,
nerve
right
roots.
there.
You know what? When you push down there, I feel it on the right lumbar.
Yeah. Well, we're letting it fall forward. Let this
Yeah,
a little bit go.
okay.
Yeah. So they were holding it down there. Okay, so right there. So that had a nice effect. So we know it has some effect on it.
Yeah.
So that's nice.
Neat. Cool
Mhm.
trick.
Okay,
Excellent.
so another thing that we want to look for is to feel the muscle and feel if it has full range. So you want to see, we looked at if it had full shortening.
Yep.
I mean, we looked
Full
at
lengthening.
full lengthening. Now we're looking at, does it have full shortening?
Yeah, you
So
want
I'm
full
putting my
shortening
finger,
too.
yes, if you don't have full shortening, what does a muscle do?
Maybe cramps or.
It doesn't really, it just sort of stays, like, I move it this way, instead of shortening, it just stays in one position, it doesn't shorten.
freezes up or something. Yeah.
So yeah, it sort of like freezes up. So it's like pickled, in these painful chemicals, because it's a little painful too, right?
Yes.
So we're pushing lightly on it and pushing out those painful chemicals. At the
Mhm.
same time, we're noticing whether all the fibers are doing their job.
That
Okay.
one I feel more.
Yeah. And of course, remember, they could cause a pretty good pain coming up this way and all the way down through here and all the way down into over the tibia right here.
Now I know it's a little later, but there's a adductor magnus
Okay,
too, which
adductor
is-
magnus, of course, is right here. Okay, so adductor magnus is really the one that refers up into the pelvic floor.
Oh,
Okay, so it's really a bad one for pelvic floor pain and dysfunction, or pain, or what you call headache in the pelvis. Refers pain into the pelvis.
Okay, so the adductor magnus refers
Right there, it's
pain.
right there. Right. But also, you see, it goes up and down the inside of the thigh.
Yep.
But that's what our area is today. But in addition, it refers into and activates and causes trouble with the organs right here, wherever all the viscera that it refers to.
Absolutely.
So it can cause really bad pelvic floor pain and dysfunction. So here we're going to look at the adductor magnus.
And yet, is there shortening when you're moving?
It's doing
in
good
that
job.
This is
Yeah,
the
so-
longus and brevis.
So I'm doing passive range of
And
motion
here's the
with my
magnus.
finger right on the muscle, and it's working. That muscle's working, but this one wasn't. This one here that causes the anterior thigh, knee, and here, this one was causing her trouble. I can feel that one.
Yeah.
right there. So this one's not working.
Uh-huh.
So I'm going to have her push down and resist and use PNF, proprioceptive neuromuscular facilitation, to get this muscle to relax.
Yeah, exactly.
And good. And try again. Yeah, right there.
Oh, that's a spot.
I'm right on it.
Yes, so I feel that.
Yeah,
So
yeah.
she's resisting you.
Yes.
A little. Yeah, I'm having her push down.
Ready?
And then, good. Let's see.
So this
okay,
is
now
how
good.
this is how you would
Good.
treat it.
Yeah, this is treatment, and so I like to evaluate the whole time I'm treating.
Yes.
You know? Now, really good way to treat it
Right,
is to
so
have her.
this
lay
is
side.
adductor magnus that she just
I
did.
just did Magnus
and
and
then she
and
did
brevis.
brevis and longus,
Longus,
there.
yeah.
Okay,
Longus
someone
and brevis,
else.
yeah.
Yeah.
We just
Yeah.
did those. That was like a quicker treatment, but we could do a more thorough treatment and do a couple different ways.
Great,
So
let's see
let's
that.
take a look at that.
Yeah.
If you could have you sit up, so you can have you turn sideways. If you hold the book for a second, and then sit up. I'm going to use the body support system. So for sideline, I almost always use the body support system.
Yeah.
And
Definitely.
this gives us a really good way to get at the adductors, and also a good way to test them. So I'm going to put a little heat here at the keyhole. Okay, and let's have you go ahead and lay on there. Put your shoulder right here.
Sharon, when you were doing the when you were moving the leg and you had your hands on the muscles,
Yes.
when you said you felt whether they were working or not, what were you feeling?
I was right on the muscle, and I could feel its attachment. So I was right on the attachment for the brevis and the longus.
Uh-huh.
So I pressed in. It was right on the attachment. So a little bit above that, I was working on the belly of the muscle. So I was kind of working into making sure, but I could feel the attachment wasn't working. So I pressed on it there. Yeah.
Okay.
So.
You expected it to be like contracting, or you expected it to be? What were you feeling? What was
Okay,
it?
so when I'm passively moving it, it should move beautifully and easily. All the fibers should move and stretch all the way. And
Okay.
now, if she was actively using it,
Yeah.
then I'd be looking for, can the whole muscle, do I feel all the fibers active?
Okay.
When I'm, so it depends on what I'm looking for, but I'm looking for both.
So when you say the attachment wasn't working right, or that part wasn't,
Yeah, it was all hard.
It wasn't stretching.
Yeah, it was
wasn't
all,
lengthening.
it wouldn't contract.
Okay,
See,
it
a lot
wouldn't
of-
shorten.
Right, it wouldn't shorten.
Gotcha,
Yeah, a lot of
gotcha.
times it won't shorten. So the
Okay.
range of motion test isn't always is good, because that's the beginning. The next you want to do, can it shorten?
Yeah. So you're
Yeah.
basically palpating,
Yeah.
treating, and doing the range of motion test at the same time.
Yes.
Yeah. Okay. That's awesome.
So that's what I always do, because
Oh, yeah.
right there, that's the same muscle now.
Yeah.
So I just have her knee up a little higher so that we can, there, yeah. So that's it right there. So a lot of times what I'm doing when I'm treating people is, especially if I want to get that higher up area part of the adductor magnus, I feel the ischial ramus. I press down and press up towards the attachment onto the ramus.
Yeah.
And then the elbow is a big tool, so it's not as painful as your fingers, and it's sort of nice way of doing it. Yeah.
Yeah.
I'm getting closer, a little bit closer to the magnus will cause pain right through here, so we're right on that. But
And
the
refer
part
to
I'm
the pelvic
on
floor.
goes up
Into the
instead of
pelvic floor.
down. Yeah.
Yeah.
So here I'm getting higher up. So you've got the arm here. You feel the ischial ramus. You press down, and then up towards the ischial ramus, and that's how you get into that area. And it's there's so many people coming to me with pelvic floor pain and dysfunction.
Even pain during intercourse.
Yes.
Yep.
Testicle pain.
Yeah.
Numbness in the urethra.
Yeah. Yep.
All kinds of pain and dysfunction. Urinating, pooping when you're trying to urinate.
Yeah.
All kinds of things that happen, and incontinence. So all those kinds of things can be treated with this area here.
If you guys would like an educational piece on that, always remember you can find lots of great articles on our website.
So, can I show one thing?
Yes, of course.
I'm sorry.
No,
One little thing. So here, I'm trying to make sure the adductor longus and brevis is working. I'm right on it where it's attaching here, and I could feel it wasn't working. So I'm like treating it and then testing. Is it working? I'm treating it and then testing it. Is it working? So it shouldn't. When I'm passively moving, it shouldn't contract.
I see. It should smoothly.
It should just relax. Like I'm just testing. Did I get it? Aha, it's working there. Okay, there. So it's the
So if it does contract, that means it's not working?
correct. It's like stuck in like one position, and when you move it, it just stays there.
So it's like
it
frozen,
doesn't-
it's not
It's
yielding.
like frozen. It doesn't contract. So, but you saw she stretched. So the trouble is, see, she passed the range of motion test.
Right. Well,
But-
the overall, the
Yes.
sum total
Yes,
range of motion test,
Right.
the gross range of motion, but
Right.
the individual segments
aren't passing.
aren't passing.
See, because I'm testing them, they're not
Yeah.
passing.
Right.
Okay, so the thing is you want to go further, you know. So these are you're mostly pain
This is
free.
more detailed, more in depth.
Right, you're mostly pain free if you pass all those range of motion tests.
Yeah.
But there's more range of motion tests.
Yeah. Every
And you need to
This is
segment.
pass.
looking more for function.
Yeah, I'm looking really for function because the name of this business is pain free and
Full function.
what's the good of being pain free if you're not full function?
Yeah.
Right? You got to be full. You have to have
Well,
your
they're both
body.
good.
You
They're both
gotta-
good.
Oh, you
Yeah.
got that right.
They're both good. Anyway, I was going to say that don't forget you can always go online
Good. We did.
and
Okay, I got one spot.
Muscle
right
News right here. You can see past articles.
Okay, now I feel it.
There's one here. Could this muscle be hindering your love life?
Is that the insertion?
It's below it, but it's close.
There's an article on the adductor magnus and how it can affect your love life and cause problems with the pelvic floor. And there's the test. See, passing and failing. See? And there's how to treat it. And this is for your patients. Of course, you learn a lot by doing it. And here's some self-care. See, already shown for you here. So that's neat. You can go through our archives of Muscle News, and you can use that too. Or
That's
you
great.
can
That's
sign
what-
up. Yeah.
Yeah, that's great. Sign up.
Yeah, sign up, get it sent to your patients with your heading on the top, and then you can start growing your business too, which is nice.
That's good. Oh, you can send it out without signing up too, just with my picture on it.
Yeah.
But if you wanted to put your picture on it,
Yeah, exactly.
then we could do that for you.
Yeah.
What, and take credit for all your work? Are you kidding?
No, it's to help educate your patients. That's giving credit.
My name is Sharon Sauer.
My name is Sharon.
My name is
Well, the real Sharon Sauer, stand up.
The real Sharon Sauer, please stand up.
Would you? Okay, turn over.
I can't stand up because I'm not the real Sharon Sauer.
I don't think that standing up would the real Sharon Sauer please laugh out loud.
Then we'll know.
Then we'd know for
Then
sure.
we'd know. Okay, so we did the other test earlier, but now we're also doing the range of motion test here. So
Okay.
this is so I put one elbow there, so the elbow
Okay.
is feeling.
Right?
And then feeling here, how's it doing? This one was the one that was better.
Yeah.
Okay, so the adductor magnus is working.
Uh-huh.
But again, I'm feeling the same thing. The longus and the brevis isn't.
Okay.
Okay, so they're here in the front. And remember the pain pattern for that one is going to come down here and onto the tibia, right onto the shin.
Yeah, exactly.
Okay, so let's take a look at it. I'm going to use my knuckles this way,
Uh-huh.
and we're going to go kind of like this. We're going to go in and up towards the ischial ramus.
Uh-huh.
I've been looking around for, okay, right there, I found it. So I'm on the brevis right here. It's not painful, but I feel that little dysfunction there. Yeah, see, it doesn't want to.
Doesn't wanna shorten.
So when I try to shorten, it goes like this, you know. So I try to shorten, it goes like that.
Uh-huh.
It gets like that hard.
Yeah.
It gets like a board.
Some muscles are more prone to that than others. Like the iliopsoas is really prone to doing that. They don't like to shorten. They get stuck in the middle. The one in
One
the neck,
position.
the levator scapula, doesn't like to shorten. That one gets stuck. It's like a frozen muscle. If you've had frozen neck, you wake up and your neck
This
is
part's
frozen.
your adductor.
That's yeah. So.
So we
Ever
found-
been in a long car ride, try and get up, and it feels like you can't straighten your hip out? That's like a frozen iliopsoas muscle. But also it could be a frozen adductor too.
Okay, let's check to see how we did. So we're gonna see if she can. So pretty good. How's it feel?
It's okay.
I'm looking for any fibers right there.
Okay, that one.
I found some fibers that aren't working. Okay, so I just went for the fibers that weren't working. I'm not treating everything
Yeah,
necessarily.
Well, we can't right now anyway.
Yeah.
We're demonstrating.
Well,
Yeah.
even so.
Even so.
It's a thorough demonstration.
Uh-huh. That's one too.
So what are you on now?
This is the adductor magnus.
Too deep.
Okay, let's see what we did. So we're gonna keep doing that till we get it so all the fibers working,
Yeah.
or if you get most of them working. I think if you
Yeah.
get at least something 1/3 to 50% better while we're treating it,
Yeah.
that's good.
Yeah.
And then later you can look at it again and then again. Yeah, so it a little bit more could be done on it.
Yeah.
Let's have you do a little self-care.
Yeah. And then how would you do
Right?
self-care?
Yeah.
Let's do self-care.
All right.
Okay, let's have you sit up for a minute. And then if you could sit on the table here. And I'll have your feet, I'll have your feet on something. Okay, so put your feet here.
All the muscle news articles always they highlight a muscle, they show the range of motion test, the patient can do themselves a little self-test. So the patient can lie on their back and do that figure 4 test, and they can see how far their knee is off of the table.
Yes,
And then
you
they can do
visualize it, yeah.
the following self-care things, which you
So this
you
is
have
the
a
muscle
handout.
we're going to be treating right here. Okay, so and right here and here. So here we're going to take a look at it on here.
And we'd say, all right, so Camille, you're going to treat this muscle. This is how you're going to do it. And then afterward, I want you to check the figure 4 position to see if you made it any better.
So if you could go ahead and use your elbow and try to do it the way we're doing it here in the picture. So have
It's
one
hard
hand
to-
hold the other hand like this and push in like that.
Yeah.
So this would be one way. So this would be one way of doing it. Use your elbow and press in like that.
That's good if you're at work or you're at a stoplight.
I found the spot.
She found the spot. So she's looking for the most painful spot, and she's holding it, breathing, and relaxing. You can't believe how painful some of these spots are.
Oh, yeah,
It's just so painful. You just go, oh, I can't believe
That's
how
why I volunteered
painful
her.
it is.
Yeah, we're pushing out substance P.
Yep.
There's
and
also,
interleukin 1 and 6, serotonin.
Yeah, there's even a little serotonin in there.
And
Feel
we're
good.
pushing in some ATP and vitamins and minerals and everything
Yeah.
afterwards that passively go in.
Yep.
So
So
that's
she's
good.
getting energy in her mitochondria.
Yeah, that's
Yeah,
right. That's right.
exactly.
Another way you could do it is you could use this jackknobber tool. So here, I often put it in like that, and press in like that, and look. So here again, be looking at pressing all through the inside of the thigh right here, and up here. Remember, we found some up through here too.
Oh, I'm finding things here too.
She's got some all over around there.
Oh yes.
And so,
everything is.
and see here, this is in the protocol right there. So she's using the jackknobber tool, but she's got her leg straight, which is fine as well. You could do it bent or straight.
Yeah, and you could bring
Here's
the leg
another
out
way.
for a stretch.
If you could also get the ball a little lower down and do it on the floor and put the ball underneath here.
Yeah.
So that'd be a good way as well. So there's a lot of different ways to do it.
Good.
I'll show you how sometimes I do it.
Okay.
So I'll show you. So we can do it together. Okay. So often I'll sit down and I'll treat like this. So I'll get my elbow into one leg, so that leg's pushing, and then this one sort of helps. And I have the knee. So I'm doing a little adductor contraction on the right while I'm doing adductor treatment on the left. So I'm getting a lot done at once.
All right.
You're multitasking.
Yeah. Okay, so this is a good tool to use, and come all the way up. And looking around for painful spots. And when you find a painful spot, you're going to hold it, breathe, and relax. Then usually I might massage it. And then a really good stretch is just to go like this. And boy, this stretches it good. So
Yeah.
give
yeah.
a really good stretch. Push in a little bit and stretch it out. Push it in a little bit. And then we can contract it. Let's see how we're doing with contracting it. And let's contract it. And let's contract it. And let's contract it. Good, and let's stretch it. Good, so we did the range of motion.
That's it. We hit everything.
Now, we're going to take a look. Now we want to test the strength, okay?
Oh yeah. Oh, we got to
So
do.
we're going to do that
strength
next.
work,
Okay, so next one we're going to do, so we're going to have, Camille, if you could lay down on the table again.
Yep, just face up.
Just hang on for a second. Let me get this out of the way. Face up. Okay.
So the nice thing about learning the strength test is that it helps you remember the function of the muscles. So the adductors, remember, they bring the legs together. They bring the knees together. So to test the strength of the adductors, you have one hand here just bracing, and the other hand here. This braces and this is going to push out that way. Okay, now for muscle testing, there are two parts to every muscle contraction. There's the conscious part. That's the part that you can control. That's why even when you're sick and your body doesn't want you to move, all your unconscious muscles contraction is off. You can still drag yourself out of bed, but it's hard, right? Because you're not getting any support from the unconscious portion of muscle control. Or if you have an injury or a frozen shoulder, you kind of lift your shoulder up, but the unconscious part doesn't want to help you. And then if you get the unconscious part firing, then all of a sudden it'll do it, you know. So anywhere between 80 to 30% of a muscle contraction is unconsciously controlled. So I'm going to have her push into my hand first. That's step one, is conscious engagement. So would you please squeeze your legs together, push in my hand, good. And then the second part is I add, you just keep holding, I add 1, 2, 3, 4, okay, 4 additional increments of strength, of resistance.
Okay.
That engages the unconscious portion. She thinks she's pushing as hard as you can, right? Push as hard as you can. But then as I add more, the unconscious portion agrees to add 2. So that's a positive test. That means her muscle is firing. Do the same thing on the other side.
So we could do that after retreat. We could check to see, are they firing?
Push in. And I add 1, 2, 3, 4, 5. Good. All right. Common mistakes are people will immediately jump the gun, so push into my hand, and they'll just jump real quick, and that causes that Golgi tendon organ to say, whoa, I don't want to get injured. That's too rapid of a contraction. It'll let go. And the other thing is some people will push into my hand and then push. Go ahead.
This it?
Yeah. And then they'll just kind of sit there and wait really long, and the patient will get tired. So you don't want to make too long of a test or too short of a test. You want to let them push in all the way, then you add 2, 3, 4, 5 quick increments of strength, and if the muscle can meet the additional strength, that's good. It means it's firing.
Great.
Okay?
Okay, good, super. So, this we checked. We found a little bit of dysfunction. She passed the range of motion test, but she
Yes.
didn't pass the range of motion test for shortening.
Yeah.
We corrected that. She had some painful taut bands. We corrected those. Then we did the self-care. She did her self-care.
Yep.
And then we did the stretch and the shortening. And then we did the strength test, and she passed it.
Yeah, yeah. And last week, just for the audience information, last week she failed the strength test. We fixed a hip compaction last week after the class was over, and she had failed it, but now
Now we activated it.
Yeah, now it's back.
Yeah, now it's
Plus,
back.
Sharon just
Yay.
worked on it, so there you go.
Yeah, we got it. We hit it both ways. Yeah, everything. It's working. So that's so much better for everybody.
So
Yeah,
step
yeah,
one,
it's
to
working.
answer the question, step one, they're adducting against me. Step two, I'm adding additional strength, additional force against them, which they have to meet. So step one, they push and I meet. Step two, I push and they meet. Okay?
Good.
Yeah. Okay.
Okay, super.
Yeah.
So what's the next most likely muscle
The next
cause?
most likely muscle, iliopsoas.
Iliopsoas.
Wow. So let's take a look at it. What's
So
that
let's
referred pain
let's
look like?
Look at great picture of iliopsoas right here.
Okay.
So we got one right here to look at somewhere. Okay, so here it is. So it attaches here on the vertebral bodies and the discs, and also on the transverse processes between T12 and L5, and then comes down and it attaches here onto the greater trochanter.
Yes, I mean it's really deep in. From the back, you can't reach it. It's in front of all the back muscles. It's
so
deep. It's on the
it-
anterior portion.
And see, here it is here, and here's the pain pattern it causes. Its most common pattern is this.
Yeah.
So when you're hurting and you say, oh, my pain is across here like this, it usually is the lower abdominals. But if you say, oh, it's here like this, it's usually like this. You're thinking like this.
Yep.
And or just like this if it's just on one side.
Yep.
Then it's the psoas. So it's sort of like the psoas goes up and down, and the abdominals go side to side.
Okay. Yeah.
So, But look at all the nerves that this muscle can compress here.
Of course.
Wow.
Look at this list of nerves, and even the last one here is also causes you to have pain in the groin, the scrotum, the labia, and the thigh.
Yeah.
So this is so this muscle causes so much trouble.
Oh yeah.
Yeah.
And you can see lumbar disc problems. This is a huge muscle
Yes.
for lumbar disc
Now,
problems.
what it could happen, part of the psoas could pull
Yeah.
on the disc and pull it forward.
Yep.
And so, what if we got these fibers to relax? Then it would be if the body was moving, it could suck back in potentially.
Yep.
Could that cause a bulging disc?
Yes,
It causes
could be
bulging
part
discs.
of the bulging
Yeah.
disc issue.
Yes,
At the
definitely.
point that the person's having the problem, the muscle might be pulling the disc forward, and if we corrected everything around the disc, possibly we could get it to move, and then it could suck back in.
Yeah,
Yeah.
plus just the amount of compression. When it contracts,
Yeah.
it compresses
Yeah,
these discs.
sometimes all of them are compressed.
Yeah.
Yeah, some
Yeah.
of them are all pushed and pressed and then sticking out like this.
Yeah. That's,
So so there's lots of ways that could be causing trouble. And what did Travell call it? Called it the hidden prankster.
the hidden prankster.
Yeah, I called it the hidden prankster. So she and also it can cause a nerve compression, the cutaneous femoral nerve compression on the outside here.
Right, that runs down the side and front of the thigh.
That's right. That's right. So that's an
So
important one too.
numbness and tingling down the
also
front of the thigh.
sartorius also causes that.
Yeah, there's a couple
So
muscles.
so here's the sartorius, and here's that compression. So here's the nerve. Here's the cutaneous femoral nerve. It could be compressed anywhere here in the iliacus, the psoas right there, the iliacus, and then as it comes on, and the sartorius, and then maybe even the rectus femoris all could be causing this numbness here, and they call this sometimes they call this, what do they call this?
Meralgia paresthetica.
Myalgia parasitica.
Yeah.
So that's definitely a problem, and so we're going to take a look at that.
Okay. Cool.
So that's we're going to look at.
Well, how would you
let's do a little
evaluate?
test.
Yeah, how would you evaluate the range of motion of
Well,
the
the one
iliopsoas?
test we could look, which I like a lot, is to see if we can get full shortening of it.
Full shortening. Okay, let's see.
So we could use the same test we use for the length of the gluteus maximus, and we could also use it for does the iliopsoas shorten? And we see no, it doesn't.
Oh,
The iliopsoas doesn't shorten.
that's not good. So it's supposed to get all the way up to the opposite.
Yeah, but see, okay, but how do I test? So what I do is I'm walking towards the opposite shoulder,
Yeah.
and then I stop as soon as I feel the resistance.
Yeah.
Okay, so
Right.
then I'm going to just check from the superior patella to the chest here, and I go pretty much straight down, and that's 12 inches, and when it's 12 inches, that you're in the pain zone.
Oh yeah.
That's the pain zone.
That's the pain zone for sure.
Yeah.
You can expect
For the-
her to be having some lumbar back,
Yeah, lumbar
some
back-
low
oh,
back
yeah.
problems. Yes,
And pain,
for
and
sure.
for this class, remember this would also cause pain in the anterior thigh.
Oh yeah.
So
Right.
it can also cause, it causes sort of like attachment pain here at the lesser trochanter above it right here, and some referred pain, and it also causes significant referred pain.
And this is one of the cases where not only referred pain, but actually problems in the back. This can really cause a lot of problems on those discs and joints when it's yanking that hard.
It could.
It gets frozen in the middle because you sit all the time, which is halfway contracted. All day long, you're halfway contracted.
And
know?
how many people all over the world are sitting at Microsoft or an Apple computer or
Yeah.
a Dell, and they're all having this trouble?
Yeah.
Yes.
Okay, so on this side, so we're going to go push. We're pushing, so we stop as soon as we feel the resistance.
Yeah.
Then we measure right down, and it's 11 inches. So 11 and 12 both are dysfunctional.
Right.
So that's a great test because it's real quick, okay?
Yeah.
But a nice range of motion test for the length of the muscle is sitting right at the end of the table. So if I can get you to do that.
So that's if it shortens. This is one of those muscles that needs to be able to shorten.
Okay, so you want to
So-
get really close. So almost off the edge, yeah.
Right.
Yeah. So for this, I'm just going to assist her, and we're going to bring one leg up, and we're going to have her lay all the way, and I'm going to just assist her going down. And then we're looking, oh, see, the psoas has full
Hey,
lengthening
look at that.
again.
It needs to be 90
Okay.
degrees or less.
And here, but she has shortening of her rectus
But
femoris.
you can see how the rectus femoris,
and
this
the-
is supposed to be at 90 like this.
Yeah, but it won't do that.
Doing.
Yeah.
Do that.
No, it's not
But
doing
see
that.
how the iliopsoas lengthens completely. So you would think, oh, it's got full range of
You
motion.
can say it has full, but we
No,
saw that it didn't
doesn't.
want to shorten.
It has
Okay.
full lengthening, but it has terrible shortening.
Okay, so let's take a look at the other one. So if I could just help you sit up again. Okay, and if I could shorten the other one. Okay, we're bringing it, and then we're going to come down. And again, we see the same thing.
Oh yeah, there it is.
Yeah.
So if it was bad, what would it look like, Sharon? If it was short,
This is if it was short,
it'd be hanging up in the air
it'd
like
be
that.
like that. Yeah.
Yep.
So
And lots of people have that too.
Oh yeah, that's big.
Yeah,
No,
that's big.
that's huge.
That's
That's
really
huge.
big. But she doesn't have it.
That's correct.
Yeah.
But who doesn't have it? Sometimes people who do a lot of exercise like stretching.
Yeah.
Sometimes people who are do a lot of yoga. Sometimes they pass all the stretch tests for that
Sure,
reason.
sure.
Yeah.
Also,
Okay, so-
that's also just bulk. That doesn't mean that every segment of the psoas is stretching.
No,
No.
it doesn't. Yeah.
You'd have to palpate and feel every segment to know that
Yeah.
each one was stretching.
So here's our iliopsoas, and its nerve roots. Also, we're going to look at the same. Remember the same nerve roots that we had before that we treated.
In fact, if you
That
guys,
helped her?
Yeah. In fact, if you guys look, almost all of them are L2 through 4, almost the
Yes,
whole
that's
way
it.
down. So you're pretty good. The only
That's
one,
it.
the
That's
QL, has a few more. Otherwise, you cover them all in L2 through L4. And
And,
remember, that's just skin rolling along the L2, L4 to find out.
Yeah, or we just treated it.
Yeah, just treat it.
And we saw whether it passed the range of motion. So we saw whether it affected. So I mean, just interesting. if
And
it did-
wouldn't you
yeah.
treat it anyway? Pretty
Yeah.
much, it's a good idea if you're working in this region to treat those. Sorry.
So 48 would be another test that we could do next here. So hip extension. So this would be for the psoas. So we could do this next here. So this
It's
would be
similar,
for,
though, to the one we just did.
But you're not. Yes, correct. So
Very
the
similar.
therapist is. It's very similar. So if you wanted to skip it, we could skip that. Yeah.
Yeah.
Okay. So let's take a look at treating the iliopsoas.
Yeah, let's look treating.
Okay.
Those two tests were
Super
the
great.
ones Sharon does all the time, as far as
Okay,
I've
if you
seen.
come on up there, we're gonna treat it.
Yeah, let's treat it.
We're gonna treat the iliopsoas.
I mean, how much less pain do you think you'd have if that knee got to the chest? If it was so relaxed that it allowed the knee to go to the chest, and wouldn't that be wonderful?
Yes.
What do you think? It'd be
That would
good,
be
right?
fantastic.
Yeah. So I'm gonna just take the abdominals out a little bit by bending her knees a little, so it's not so.
Oh, that's right, because it's real deep behind the abdominal wall.
So here's the umbilicus,
Okay.
and then I'm gonna come lateral a little bit, and I'm gonna just a little bit around the rectus abdominis and come on in and towards the spine.
Yeah.
So here, so I'm not getting too close to the iliopsoas right now because I'm dealing with
Right.
the abdominals, so I don't want to go any
Sure.
farther into the abdominals right this second. But it's still even treating over it.
Uh-huh.
Is I got it now. I can feel it. Can you feel it?
It's fine.
Yeah, good. So I'm on it now. I can feel. So I got it. I went a little deeper. Yeah, just after a second
I'm
or two.
just breathing, but it doesn't hurt.
Good.
For the person who asked the question, the skin rolling is how you detect.
Oh yeah, I'll do that next. I'll show.
Yeah, we'll show that in just a
we'll show in a
second.
second. Yeah. So we'll show different ways.
Yeah.
Yeah. So we already did it that one way. Now we'll do it another way.
Yeah.
Skin rolling is a really good test.
Yeah. It's also kind of like treatment, but the real treatment is to go in and compress the multifidi and rotatories, all little muscles that are responsible for compressing that nerve.
And all the little fascia and stuff, and the periosteum around the bone and stuff.
Yeah. You even, I mean, remember, anywhere where there's a pain nerve that could send signals that cause a problem, you need to treat those tissues. Even the periosteum around the bone
Well, it's
is
so
part of the
important.
fascia.
Yeah, it's so important
Yeah.
though. It's like
Some people would think you can't push on a bone, but you sure can.
Yeah, it's so exciting.
You push on a bone. When you first realize you can is when you push on a
Nothing
bone
hurts
and it
at all.
hurts,
Nothing.
and then you work on it and it stops hurting. Then you realize, wow, I've just made a huge change. So.
Yeah. Okay, so we're gonna take a look on this side, same thing. So we're find the umbilicus, come a little bit lateral. So we're gonna get just a little bit to the outside of the rectus abdominis. And first I'm coming down and I feel just the resistance. So I stop where I feel the resistance, but I know the direction I want to go. I want to go towards the spine, right where the trigger points are for the iliopsoas.
Yeah. So with each breath, you're kind of going in a little deeper as it
Yeah,
relaxes.
just holding it and just going in a little deeper.
Okay.
So is it in and is it up or
So
down?
so this is so it starts
Or
up
an
here,
angle.
but the trigger points start here, about here, and you come lateral to the umbilicus. You go in, and then towards the spine,
So
Yeah.
toward
thought
at an
so.
angle,
So
like
down
at this
and in.
angle. This, I missed
Down,
that.
and I said I felt that one a little bit, but
Yeah,
it doesn't hurt.
Yeah, I'm on the psoas now. Yeah, I can feel it. So it feels more solid, like you're in the abdominal cavity and the abdominals, and they stretch.
Yeah.
And then you've got other tissues that are stretching. But here now I feel this super solidness of the iliopsoas there.
Yeah.
and about how deep is that?
Well, let's see.
3 inches?
Well, just
Two and a
about,
half?
just about that deep. So I
Yeah.
guess it's about 2.5. Yeah.
And there will be things in between your hands and the psoas, but you're getting to the point where you can feel it. So
Now this low down, we're more on the intestines.
yeah. But it's good actually.
We got to move them around. That's good.
Yeah, there's no problem. Don't feel, in fact, the ileocecal valve over here is a great thing to work on. And the valve of Houston's not a real valve, but it's an area that helps with constipation and or diarrhea. So there's, this is really good to work on those anyway. So,
So here, I mean, so now I want to go really deep.
yeah,
Okay.
this is where we're
So
gonna
this
get
is because we want to really get the iliacus. So we got the psoas part, but we want to get the iliacus.
it. Yeah. The iliopsoas is a combination of the iliacus and the psoas.
So this part here,
Yeah.
this is the part I can feel doesn't want to shorten.
Yeah.
But I'm getting it to shorten a little bit now.
That's
So
it.
so I'm going to encourage it a little bit
Can
to
you,
shorten.
can you show your contact?
So here's where I'm pressing. Okay, so it's right where so here where I'm going to be right in
Yeah.
the inguinal ligament here, right?
Yeah.
Okay, so I'm right there, but I'm going to be going this way, this way, this way, this way, this way, this way, this way. So I'm going every way. So it's like there's a huge property in there. Okay, there's a huge amount of stuff in there, but it's all accessed right here. Okay? So that's what we're doing here. So in order to get deeper, I'm taking it and putting it on the short.
Yeah.
Okay, so
Yeah.
now could you push towards Linda? And then relax. Okay, so now push right towards the Allerton Hotel.
Top tap, right?
Right towards the tip-top
Tip-top
tap.
tap.
You mean the tip-top tap?
It's more fun than me. pushing for me.
Linda's not always there, but tip
Okay,
top tap
now
is
towards
there.
Children's Hospital.
Okay. I have a friend who works there.
Push toward your friend.
Oh, okay, now Northwestern.
Towards the lake?
Yeah,
Towards the lake,
yeah.
towards the lake, towards the
Push
lake.
towards the lake.
And relax.
Yeah.
Okay, so it's getting a little closer.
Yeah.
So when you go around in a circle,
Yeah.
what exactly
So
are you
I'm
doing?
looking for range. So I'm looking, does it do everything? So I'm looking for, is it doing all this ranges of motion?
So you're assessing
So,
it
yeah,
when you're
yes.
rotating
Yes, I am.
around
yeah,
in a circle.
Yes, yeah, because you should be able to do that. So you should be able to
So
move
you're
your
looking
leg-
for range of motion.
Yeah, I'm looking for all range of motion in there. Now we're getting way down in there in the joint, near the joint capsule in here.
Now, it's just worth mentioning too.
Right there.
What
Okay.
if doing
Push which
this? What if doing
Children.
this doesn't help the knee to chest?
Analyze.
Don't forget that the glute maximus is also
yes, yes.
responsible for the failing
Yeah,
of the knee to
push.
chest
Which
test.
way?
Yeah, you're doing it perfectly. Emily. Yeah.
So,
Okay, so here we're doing quite a bit better.
Yeah.
So you can see that we're getting closer to the chest. Okay, that's really good. Okay,
Yes.
let's take a look at the other side.
Okay.
Okay.
That one's tighter.
But this side,
think.
I'm going to have you treat.
Okay.
What do you think? I'm going to try?
No.
Okay, I'll do it.
yeah, why
I'll
don't you
do it.
show us
I'm
again,
gonna do
Sharon?
it.
Yeah, I think you better show us
I'm going
again.
to do it again.
I
Yeah.
think you better show us again.
This is so important.
That's a hard place to treat on yourself.
Okay,
So here again, we're just going to take a look. So it's going, so without any pressure at all, I'm doing the same measurement. And we were 12 before, and now we're 8.5.
Oh, great.
So if we can
this
get,
is-
if we
that's
can do
good.
from 8 to that's great.
Yeah,
So
that's
it's down
great.
to 8.
That's
That's
very
very
good.
good. So let's
Very
take a
good.
look on this side. So here I can feel the resistance right there. Okay. So we're gonna go ahead and hold on to it, and so we're gonna go ahead and look at it again,
Okay.
and then we're gonna have you resist and push there towards the range of motion posters, and relax, and straight towards Linda, and relax. Good. And towards the doorway, and relax. And push towards the Lake Michigan.
Sharon really focuses on function. She is teaching this muscle how to function. I mean, it is really, she's the boss, and the muscle knows it, and the patient on the table knows it. And
This
it's
would be
this,
hard to do on
you know,
yourself.
she knows that the muscle can do it. So even when the muscle says, I can't do it, she goes,
Yeah.
yes, you can.
Now,
and,
a lot
and
of
this
times
gets it.
you're right, Justin, because a lot of times it's like it almost like it feels like it's gonna break.
No,
It
yeah.
feels like it's gonna break, and then it breaks through, and then all of a sudden it's perfect. You know,
Yeah.
so
Yeah.
it's no pain. It's everything.
Yeah, true.
Oh, thanks. You can't find what you want.
Also, Sharon didn't mention it yet, but you know how Sharon checks for leveling of the hips
Okay,
and
push,
leveling of the
push,
shoulder?
and then relax.
How
push.
many times do you,
And
how,
then relax.
how important is the psoas?
And relax. And push. And relax. Good. And push. Good. And push. Great. Okay, so let's see how we're doing.
How important is the psoas in having the hips level and the shoulders level?
Oh, it's like so important. It's one of the biggest causes of scoliosis or
Oh, yeah.
big S curves or double curves.
Yep.
So it can be a really big problem. Yeah.
It's
Yeah,
almost
definitely.
worth making sure that you don't do, you never let the patient off the table without working a little psoas. I mean, so critical.
Yeah. It's so important.
Anytime you see unlevel hips or unlevel shoulders, get that psoas going.
Yeah, it's really, really good. Yeah. So I'm just taking a look at a little bit more range of motion. I got the hamstrings stretching at the same time.
Yeah, they're tight.
Yeah.
So do the muscles remember this?
Yeah.
Yeah, that's the whole
They do.
point.
Yeah,
It's,
so-
especially,
how do
yeah.
you get them to remember? You want to then, you're going to keep doing some of the stuff we're doing every day, and then it remembers. So
Yeah.
then you come back to me and we look at it again. We're going to do this 4 or 5 weeks in a row. I think we're doing these muscles, and so, or
okay.
some of the muscles
Okay.
over again.
Good.
So it's good that we're going to do that, and you guys can continue to do it at home. You know.
Well, and
Okay, so-
it's good that the muscle, it feels like it can't do it, and then when you push through that to get full function, the muscle, it's like it suddenly remembers, oh, that's right, I can do that.
Okay, so
Yeah.
we're going to take a look at you standing up for just a minute.
Okay.
And we're going to use the skin roll test and look for L2, L3
Okay.
in there.
Yeah.
Okay, the 4 in there.
And actually, we might as well, even, all of them are L2 through 4,
Oh, we
except
could do
we
them
have a
all.
little bit of, the
T-
QL
T-
has
T-
some T12.
T12, yeah.
And, yeah,
Okay, so
yeah.
we'll look at them all.
Yeah, we'll just look at them.
Okay, so let's take a look at the heights of your shoulders. And we already treated your.
Yeah, we already treated the psoas, so.
No, I mean, you want to look at that.
We will for 1 second. So just want to look at the height of your shoulders first.
Alright.
So here we go to the supraspinatus fossa right here, and then we're going to go like here. You see, oh, this one's a little higher. The left is a little higher, and the right is a little lower. Then we're going to come over here, take a look at the sulcuses here, and you see she's fairly even there. Okay, so that's
Well,
pretty
we
good.
did just treat it, so.
We did, and that would be good that she's even. Okay, so that's really good. Okay, so now we're going to do a little skin rolling, and we're going to, well, the ones we're concerned about are up here. So if you want to hold this up for me, this right here.
Yeah.
Tuck it under.
Tuck it under, yeah. Let's do it.
Yeah.
Let's tuck it under.
All right.
We'll do it that way. Okay. Okay. So we want to see it standing. So and maybe laying down. Okay.
Uh-huh.
So standing, we can see. So here it's pretty. So it's very tight right here. So this would be around L2. This would be L. So here we go. L5, L4, L3, L2, L1. So about right here, very tight. So here. So the skin doesn't lift up very easily. And then here, oh, L3,
Wow, I
L4,
can
very,
see
won't
that.
lift up, okay? Here,
can't
won't
even
lift up
grab
at
that
5.
Take it a hold
Won't
of
lift
it.
up
Can't even
5,
get a
and,
hold.
oh, okay.
And this is what we found last week.
Yeah, so,
We after fixing hip compaction, we still had a very weak hamstrings and glute max, and so we know those same nerves that we're working on today. So you could see just how likely is it that she's going to have problems with muscles in her legs
so that
that
yeah,
receive nerve input from those
that
areas.
you would have it, yes.
Oh
So
my
here's
gosh.
L1, L2, it's very tight, L3, L4, L5.
Oh
So,
my gosh.
so on this side,
Yeah.
the L2, L3, L4, L5, all in here. So what we'd like to do is treat this till this comes up easily.
Yeah.
Okay,
exactly.
so that would be one, and so it would be one way of fixing it really good. So we have a few different ways of doing that. Let's also look at it when she's laying down.
Yeah.
Okay.
So a whole bunch of viewers are on right now. So you, just to review, when there is impingement of the nerve, the likely muscular causes are the little rotatories and multifidi muscle along the spine, the intrinsic muscles of the spine that you can't control consciously. We talked about muscles that you can test, those little intrinsic muscles of the spine, like everybody wiggle your third lumbar vertebra. You can't do it at all. That has zero conscious control. And that's why they're called intrinsic, part of the reason they're called intrinsic. And all those muscles are right in the area where the nerve comes out through that little hole called the foramen, the intervertebral foramen. And when the nerve comes out, if it gets pinched by those little tiny muscles or compressed because of the position the vertebra is being held in, then you get increased tone in the muscles that nerve goes to. And the very first muscles it goes to are these little skin muscles right along here. So by rolling the skin, you get a very accurate test, kind of like a surface EMG, of whether there's nerve compression in that area.
Yep.
But then that compression is going to affect any number of nerves through the entire distribution. Remember, the lumbar spine feeds all the nerves that go down the leg.
So we're going to take a look here.
Can I scoot down so my feet are
Yes. Oh, I love that if they did that.
more comfortable?
I prefer that so much.
Yeah. I'm not that tall.
Right. I think that's so this is the way she wants it to be is the way I want it to be.
Yeah.
I like the
Ankles relaxed.
Because
up
I don't
there.
want the toes pointed to shortens up for these muscles in the back.
Great.
So here I'm just going to warm it up a little bit.
So this is just critical for this patient. I mean, you as a manual therapist, I'm telling you, you can do more good than almost anyone for this patient right now just by doing that skin rolling. And when your goal is to make that skin rolling correct and fix that, by the time you fix that, you will have done so much for this patient. It's incredible.
So I forgot to do this first, but if you want to do this before you put on cream, here you can do the skin rolling here. You can see it doesn't lift up as much. So when she was standing, it was worse. So that shows that there's something postural happening.
Yeah.
So something with her feet, something with something else. So that it could be the abdominals, it could be the psoas. Yeah. So something's aggravating this and causing this to be worse when she was standing.
That's right.
Okay?
So standing, implicates the feet. Sorry. Remember, she's, she may have Morton's foot. She may have other dysfunction in the muscles of the foot, and then also it implicates all the core muscles. Any of the trunk muscles are implicated when you're standing too.
So here we're going to find the spinous process. We're going to come just lateral to it, and we're going to press towards the spinous process, press towards the vertebrae, and then press towards the transverse process.
I don't understand this comment. What's this, Dr. Phil? I don't get this. Someone's going to have to explain that to me.
Dr. Phil.
Dr. Phil.
Wrong program.
Yeah, I thought Dr. Phil was a psychotherapist or something.
This psychotherapist,
Yeah,
yes.
I thought so.
Okay, so here's the spinous process. So we're going to come just lateral to it.
Yeah.
We're going to press in and towards the spinous process, towards the attachments of the rotatories and the multifides.
Yes.
Pressing the bellies of them straight onto the vertebrae, then press towards the transverse process where they attach.
As small as those muscles are, you have to get the whole muscle, and just pushing straight down doesn't do it. Remember, each of those little muscles also has Golgi tendon organs, like we talked about. How many times do you think you might get Golgi tendon organs in the low back shutting off your one level of rotatories or one level of multifidi, causing that vertebral segment not to move? Then you go to the chiropractor, he moves the segment for you, but if he doesn't fix the origin insertion of the multifidi, it's not going to keep moving, until he moves it again. So it's so important what Sharon's saying about, going toward the spinous process to get one origin and insertion point, and going out towards the transverse process to get the other origin insertion point. It makes all the difference.
So I can feel some dysfunction right here, especially where we notice the standing dysfunction.
Yeah.
So I can feel it right here. So I could feel it with my elbow, but remember that I could, even if I was using your elbow, I could feel it through her elbow also. So it's like I can feel right through my elbow, and I could feel through a tool, and or I could feel through another person's elbow. the same trigger points. I can feel exactly where they are. So it's like I get good at feeling through things.
Yeah.
It's the Sharon Geiger.
Yeah. Well, it's a sensate intelligence.
Sensate intelligence?
Yeah, or tactile intelligence. That's what I meant. Tactile intelligence. It's not describable in words, but your hands have their intelligence, you know.
So I can feel some little dysfunctions right here. How's it feel?
Feels okay. It's a little tight.
So many times I'm working, along with everything else, I'm working a little bit onto a person's nerve roots, you know. So this is every time they come in, maybe for 3 weeks or a month and a half, and after a while they come in and they're not uneven anymore, and all their nerve roots are working. Yeah. So here again on this side, so we're going to find the spinous process. Going to go a little bit lateral, press in now towards the attachment onto the spinous, then onto the belly, and then towards the transverse, and then move it around a little bit, and then we're going to move down a little bit lower. Again, feel the spinous come down. We're pressing out. I find some dysfunction here. Do you feel it?
Yeah.
And you know, having these kinds of tests, the patient gets excited about the process. You know, we have patients come out to the front. I really want to be able to pass that heel to buttocks test. You know, I really want to be able to pass this test. You know, so having tests, it keeps you on task. You remember, you know, I want skin rolling to be excellent in the lumbar spine. You know, and then you work at it for 3-4 weeks and see if you get there. So right now, if this was my patient, I would say, okay, Camille, you know, based on what I'm seeing, I want you to be able to pass this knee to chest test, knee to armpit test. I really want you to pass that, and I want the skin rolling to be really smooth and loose in the lumbar spine. Those are going to be our 2 main goals over the next couple weeks. You know, I mean,
okay, so here
great.
It's coming up pretty good, but then right here it's not coming up as good. So I'm going to look there a little more.
Yeah.
So right here. Okay. So I can feel the little muscle. So I can feel it right there. See, I can feel that with my elbow.
I see it flipping over it.
It's
Yeah.
flipping over it.
Yeah.
That's a little rotatory right there. So.
Poor little guy. Doesn't know what's about to happen. Has no clue.
Oh, that's a great spot. That's tight.
Oh, I'm having rotatorius envy.
So was I, but I didn't want to admit it.
I need some elbow love.
That's it.
Well, I was going to ask, can you do the same thing with fingers or knuckles?
Yes. Okay. So I like to use my knuckles here too, but the thing is I am trying to find. Okay, I have found that I just use my elbow wherever I can. Then my hands are always ready. You know, my hands and thumbs and knuckles are all ready. But I love to use my knuckles. I love
That's
knuckles.
a good spot too.
Yeah. So these are going to go. This is our S's, and they go to the adductors and down.
Oh yeah.
You know, into the obturator internus. You know, so these are going down to the lower leg and
that
foot.
one's real tight right there.
So these are the ones over the sacrum. So they're very important. They didn't go with most of our muscles we're working on today as much.
Yeah, not as much, but certainly for that whole hip region, they're very
Well, that's
important.
good. Oh, it's better. Okay, so it's lifting, almost lifting there, but not quite. Okay, so we're just going to look. But again, we don't have to get everything done in one treatment.
Right.
But
that one refers into the glutes.
Oh, this one refers down. Okay, so, but each time they come in, we're going to work on this and have them continue to work on it. You know, they could have their partner or their friend check to see if they have if their skin, or even you could check yourself. You
Is
could
it
feel,
L5?
You can feel if better,
The one
better,
that refers?
but
Was that
better.
L5?
Look at what'd you say?
Was that L5
L5,
that was
yes,
referring?
yes, L4, L5, yeah, L4, L5. Okay, it's coming up now. Look at, oh, it's exciting.
Before break, we better quickly do self-care for the iliopsoas and maybe how would you do self-care for this? And then
Yes,
then we'll
do
break
it.
and we'll do the
We'll
rest
do
of the
it.
muscles after break.
Okay, so if I could have you come up on your hands and knees, we're going to do a little stretch for this. We're going to do up like a cat.
Sharon, what if the
And slouch
patient
down
had
like
a
an
lot
old
more
horse.
body mass? What if we were dealing with a heavier person?
It's so easy to work with them.
Still, you can still
Yeah.
feel the rolling.
It's really very easy.
Okay,
Okay. How heavy? I mean, I think if you had an extremely heavy person,
Yeah, a beef
but it
person.
still would work. I mean, but yes, I mean, I think there is a few issues with working with very, very heavy people, but I think you have to sort of just work through, work through it.
Yeah.
So here's the stretch, and I could feel there's some dysfunction right here. So I'm just treating it a little bit while we're stretching, and so I'm sorry, I'm taking
So she's
another
doing.
opportunity.
That's all right. Cat, camel, treating the rotatories on the stretch now. You see.
Yeah.
Also, we could have her kind of rotate her
And slouch it
her
down.
shoulder to the side.
Slouch it down like an old horse. Slouch down like, yeah. Stretch it up like an angry cat. Good, a little better.
She could even turn to one side, then you could get while they're rotating.
Yeah, we could do a little rotating. So let's do thread the needle. So now we're gonna go like this. Watch me. So this I'm gonna show you. Stay right there. So you're gonna do thread the needle. So you're gonna come like this and go under. Yeah, and then you're gonna. That's it. Yeah. Mhm.
See, it's a rotation in there like that.
Is your head's okay?
And what's the purpose of this rotation?
Because we're gonna get a little. Because what do the rotatories do?
Turn.
Rotate.
Yeah.
So they also extend a little, but I mean, they rotate.
Sometimes a muscle won't exhibit its dysfunction until it's in a lengthened or shortened position. Then it'll demonstrate.
again.
So is that a lengthened position?
Yes.
It was, yes.
Exactly.
Okay.
Well,
then
one
let's-
side
let's
lengthened,
tra-
one
yeah,
side short.
The other
Yeah.
short, yeah.
Okay,
Okay.
let's thread the needle on this one. Good, there we go. So let's do thread the needle on that. That's really good. And again, we could use our elbow. Or we could use our knuckle. And I'm stopping her from falling off.
That was falling.
No. I'm just saying. In addition, it makes them feel comfortable.
Yeah.
It's like I've got a hold of them.
Yeah.
Okay.
So I don't
And then-
move.
Then they don't, but they feel comfortable. They're not going to
Yeah,
fall off. Yeah.
I like your style of working that way because it's very it feels very secure.
The thing
Yeah,
is,
you
You know,
feels
it's
secure.
not like I have to
I'm
use
gonna
my
flop
muscles
all
to
over.
brace myself so she
Right.
doesn't push me off
Yeah.
the table.
And
You
so-
know.
the thing is, Sharon is going to get it. That's the point. The function, she's going to twist it, turn it, compress it, stretch it, anything she's going to get it. She knows
Where
what
do you
she
want me
wants
now?
it to do, and she's going to make it
Lay on your
happen.
tummy.
And
But
that's
she won't lose you in the process.
right. And she won't lose you in the process. That's the key.
Lay sideways with your and face towards Justin. Okay.
Focusing
You're
on
gonna put your
function
head
is
on
so
this
good
little-
that way.
This little pillow.
It's a little
Okay.
ball pillow.
Oh yes.
Or do you
Okay,
like
so
this
you're
little
gonna.
ball or the sausage?
That's nice too. Yeah. Okay, so here you're gonna find your umbilicus, and then you're gonna lay your body onto just the amount that you feel comfortable.
roll
So you
right
just
on.
kind of, like just like that, and you're gonna press right onto it. And if somebody else could also help you by pressing you onto it, and you could have a different pillow if you like. Okay, then you're gonna go a little lower. So here, remember it attaches over here on the lesser trochanter.
Mhm.
Okay, so you're gonna come like that and press your body onto it.
This is a 7-inch ball.
This
Right.
is a 7-inch.
You could also use a 5-inch.
Mm-hmm.
smaller
Or
ball.
we could try a little smaller ball here. See how you like this.
So is this the self-care?
Yes.
This is self-care.
This is
This
a
is self-care.
self-care.
Thank you for mentioning that.
Oh, you give me the torture ball.
Torture ball. They're right there. It's going into just over the inguinal ligament and then lower. And then right there. Yeah.
Oh yeah, that's the torture ball.
Okay, so that's a really good way of treating it. And then we want to go and lay on your back. Lay on your back next, and you could have a little pillow if you like it. And then here, we're going to go, and so we're going to come like this and treat right there. We're going to find the spine and then press right there.
Okay.
And then we can move the pelvis a little bit
Sure.
around while we're doing it. Okay.
Okay.
So we could, often I like to come underneath. If we could bend the knees and get your back flat onto the table. So we're going to let's come to about L1.
L1.
Okay. So let's come across to the other
Oh,
side.
we're on the other side.
Yeah, so
Okay,
feel the other
opposite
side.
side, yep.
Okay.
Yes.
Okay, now you're in the little lamina groove. Okay, now
Mhm.
you're going to press your body down onto it, and you're just going to very gently, with hardly any pressure on your arms, just relax as much as they can be. You're just going to pull that way. Okay, so it's just even hardly any, you know, and then if you could move a little bit, like the pelvis in all different ways, and then relax. Okay, then let's move it down, go a little lower. So she's on the right side of the spine. Okay, to press into it, and then let's go to press a little. How's it feel when you press in?
Feels good.
Okay, good.
So are you trying to create mobility in the spinal segments?
Yes.
Okay.
Okay,
Someone
so-
asked about the abdominal aorta when lying on top of the ball. I mean, you know, the chance of them having a problem with the abdominal aorta is so small, and if anyone is concerned about problems with the abdominal aorta where it starts to rupture a little bit, go online, look up abdominal aortic aneurysm, and read the symptoms. If that symptom walks into your office, trust me, you're not going to be treating it anyway. Those people are in severe agony if you're having an aneurysm of the abdominal aorta. And this really, first of all, the ball is off to the side, so it's not going to get it. And really, I mean, they would have to be minutes away from death anyway if doing this kind of self-care would cause a problem.
Okay, so
Yes.
So let's go ahead after we did that. Then we're going to go ahead and go look on the other side. So again, we're going to come this way. So see, we're getting the tool on this side, and then we're going to get right. I feel this go about L1, and we're going to get the tool right in the lamina there, and you're going to press your body down onto it. So pelvic tilt down, and then you're going to take your tool and bring it over to the other side, and then move a little bit. Yeah, twist, twist, twist,
I can't
twist.
take as much pressure
Yeah,
there.
just a little. Then go the right amount. Yeah. Okay. Yeah.
Not as tight there.
Then now let's lift up. Now you're going to go a little lower.
Great.
Okay, so that's our self-care, and then we're going to do, Justin, what we're going to do next, we're going to do some strength testing.
All right, we'll just do last strength test for the iliopsoas. All right, I'll switch the cameraman.
Good.
You're in the right position here.
Okay.
All right, so let's just, we'll have the legs down like this. The iliopsoas, remember, it comes this way and then it wraps around. So it's got this twist in it, right? So it twists like that. So I'm going to take this point and bring it out until it's straight. See, the muscle's like this now, as opposed to wrapping in and twisting like that. See, now it's straight. You see, when you want a muscle test, you always line the fibers up so all the fibers are in a perfect line. And then I would ask her to hold this up. Okay, hold that up, push up into my hand, and then I'll add 1, 2, 3. Now that's probably pretty weak, right?
Yeah.
Push up, yeah. If I even add one increment more, it just gives up. I mean, she's having a hard enough time just holding the leg itself up.
Right.
When you have this kind of leverage, now this is a 3-foot lever arm. I'm not going to be putting any body weight. I mean, I'm really only adding a little increment of pressure. So first, just see if they can hold it up. Brace this other ASIS and hold up. Okay, then add a little more, I mean, I can't even add 3 pounds probably.
Yeah.
Let's try the other side. So again, here's the muscle all twisted in. So I'll cup the foot like this, and I'll bring it out. So now the muscle's all lined up. And I'm going to push directly perpendicular to the line of the muscle fiber. So push straight up, push. No, and I can't add even more, okay? Now, what could be causing that huge problem? If it's something in the nerve roots, I would have her place her hands right underneath that lumbar spine. This is acting like a little wedge. It just releases the tension that those little multifidi and everything are causing. Just takes the tension off, and it might ease up the nerve pressure a little bit. If the body likes that, oh, you lifted that up easier.
Yeah,
didn't
it's
you?
actually stronger.
Now push up. Oh my gosh, 1, 2, 3, 4, right?
Big difference.
Yeah, big difference. Come around the other side, let's see. You can see even as I let go, I want you to watch the spring. So push up in my hand. Now I add, then spring. You see how she's even got some extra strength. You see that little spring? So that muscle is definitely having its problem with the nerves.
So what if we treated those multivities and rotatories more, and we could see over time whether she doesn't get stronger?
Yeah, that's exactly what it
Would that be
means.
great?
Yes.
Yeah.
So it wouldn't be great if we kept treating them, and then after a while they got so strong.
Yes.
Yeah.
Right.
But it shows that that's probably it, the thing
Right.
causing the trouble.
Okay.
So definitely. So we noticed it was better when we treated it in a different way, but we keep treating it.
Keep treating it.
Mhm.
And other muscles, maybe like the QL or something
Yeah,
like that,
other
that
muscles, yeah.
also affect the compression of the spine.
Yeah, other
When you
muscles
get the
might
right
be-
muscle, but we
Yeah,
know
we
that
can check it.
yeah, we know that the nerve roots are definitely causing a lot of problems in
And
this
there still
case.
could be more things causing trouble.
Yes.
Okay, so it's time for a break.
Okay.
Okay.
So we're going to take a little break and come back in 10 minutes.
Yep.
Okay.
All right, thank you very much. Someone mentioned a link that they found useful for looking up muscles.
Let's check one thing. Want to treat this a little bit more.
Yeah, go
Okay,
ahead.
go ahead and lay on your table.
Yeah, my bed.
Okay. So we're going to treat like we were.
So you're doing in between
Yeah.
L2 and
Okay, so we're going to do it this way. So I'm going to treat them and see how much it improves the psoas from this ability to show.
Just from this.
Yeah, yeah, to see. So we just see. Okay, push towards me a little. And push. And release. And push. And release.
I know this may be kind of obvious, but how does treating it actually strengthen the muscle?
Because if it's getting heightened tone, it's too much tone, and then what's happening is then it can't contract because it's heading. It's making
So on the break,
everything-
if anyone would like to look, here's one of our students sent this link to a
so it's making
3D
all the
anatomy
skin-
that is, I guess it's free, that you can get for your iPhone. I would imagine it's Androids too, right?
Everything, like
And
But
that's
look at all these cool shots. You can get this totally for free. So
Is the tightness.
we'll download this for
So-
sure.
The relaxing, the expansion.
Cool,
Yeah,
thank
so
you guys.
strengthens it.
Yeah, because then it's one thing, only one thing. But but that's one thing. So you can't get farther than that. That's one important thing. Okay, so let's see what we did there. So let's do that. Okay, so let's see if we did. So we go ahead. Let's give it a nice. Okay, so go ahead and push up. That's good. And we anchor the other side. Go ahead. That's a strong girl.
No, gave out.
It gave out. Yeah, I saw.
It could be tired too, right?
Oh, well, just just checking.
But I mean, when it gives out like that, it's the muscle fatigue from.
No, probably.
No.
It's probably more.
Put on a little music.
There's more stuff in these.
Thank you.
Yeah, yeah.
Lots of stuff.
So,
Can't.
Stephanie, you're not getting examined today.
Is there any music coming?
How many? That's good.
I told you.
Oh, you did tell me you did that.
It's not hearing anything.
It's not.
Try YouTube then maybe or something. I don't know what's that.
It's kind of weird. That's what
Well, it's
my fault. I moved this here.
How accident.
No, it's all right. The internet's going fine. But it's like got red on here. What's that mean? And the sound.
So, but it's good if we can pass all the nice motions. You also need to.
I've never seen it red before. have you?
Rotation has to.
Yeah.
That's the good thing.
Right. Let's get it over here.
this is active and stretched.
Oh, great.
Yeah, yeah, yeah. Holy moly.
I gotta get root beer. Treatment.
Every drop of sunshine, every drop of rain, every Every time the wind blows, I hear it. Every time the flower grows,
I wouldn't say that.
oh,
I wouldn't use
baby
that expression.
cries.
Process. I wouldn't say that.
Everything that's young and
This is what
old
I do. I'm treating people. I
lives
never treat them
now.
really more than like an hour because
I don't know what's out there
let's say
way behind the sun.
my grandparents treat me for 3 hours.
And I've got a feeling
3 hours.
that we're not the only
I told
one.
her to jam her out. She said, no, Sharon, it's coming. No.
I can see miracles
Full function.
happening all the
I kept
time,
moving in.
and I can see
To make sure at night that I
eternity
had
through
something that wasn't
infinite
like
eyes.
this or something. I got up the next morning. It was like I never had anything. It was like I had frozen shoulder 3 hours later. I didn't have frozen shoulder, and we over-treated. Wait,
I was just a thing.
yeah, but I wanted to work tomorrow morning.
Just
I
the
thought this
other
was 6 o'clock at night when I had the injury. I was treating
Not some other universe,
I never
not
had it
so
before or after.
far away.
So anyway, so I said, no, we're going to fix this now.
Maybe I'm
And
an
then I
idiot
never had it ever since.
from a
So
neighborhood
I'm just
star.
saying, and so it banged it right out.
Maybe I'll just fly away on a slide
You know
guitar.
how to do all the self-care and keep it moving, and that you're willing to deal with the soreness and dysfunction that you have.
And I
Yeah,
don't
the
know
average
what's
person
out
Because
there
they hate you.
go to bed. And
way
you
behind
know,
the
And then
sun.
they'll hate you for making them too sore.
And I've got a feeling that we're not the only one. And I can see miracles happening all the time. And I can see eternity through
Yeah, but
infinite
like,
eyes.
Yeah. So she meant to tell you she wasn't going to be able to eat.
Oh, okay. Oh, she's resting. Good, that was good. Good. So she stays with, if you could advise her to stay with, hot baths and doing different things. So, yeah, good. So great. So how far did we get?
Well,
We did 3 muscles. Well, we did the first 3.
yeah.
And that's true. Between the first 3, the most important.
That's fine.
Okay.
We'll just
All right.
move quickly through the rest.
Okay, 33. And then we'll do the same. This is the heel to the buttocks too.
Really 4 because we did the nerve.
Good. Yeah. Super.
Okay.
Sartorius? Yeah, so the pectonis is right here. A little bit. Oh, down, too bad. Let's take a look at it here. So pectonis is the fifth most superior
Her name's Muscles, not even Hornet's Nest. Mine's real big.
Yeah, how crazy. You can't relate to that. You can't relate to a hornet.
Okay, we're not related.
Yeah, those are hornets.
So for the next yeah, let's and of course,
I hit both my knees on the dashboard. They don't give out, so you start to climb.
Okay, here we go.
Jammed.
the jammed in there.
Yeah,
Jammed.
my hand did too.
Just a jammed.
Yeah, I got jammed in the hand too. Went to the
Gee.
steering wheel and hit the dashboard.
Man. It's incredible.
Okay.
I don't know how my hit the gear shift.
You need to be
but it
jellied
did.
instead of jammed.
There we go.
Sharon's ready to
Okay,
jelly.
here we are. All right, everybody, hope you enjoyed your break. That anatomy link was pretty cool. Again, someone wanted to show us that. It's 3D Anatomy is the name of it. It's called 3D Anatomy, and it's on the Apple Store, so you can get it for your phone. One of the students shared that. Looks really cool. I mean, that's some neat stuff. If you love anatomy, then that might be something you can get for free, I guess, this week. Okay? All right, so thanks for sharing that. All right, we've got a few muscles to go through left.
We're going to do the rectus femoris and the vastus intermedius.
Yep, we'll do those
And
together.
Yes, and but the rectus femoris is the 8th most likely muscle to cause the pain and dysfunction there,
Yeah.
and the vastus intermedius it would be the
Fourth most.
the fourth most likely.
It's
So
not
we're gonna do
necessary to
the-
memorize the order, of course.
Oh no, but it's interesting.
It's
you know,
interesting,
that the
yeah.
rectus, the muscle that's on the front of the thigh, is the least likely one to cause it.
Yeah, that's interesting.
So just as interesting, isn't it?
Yeah.
Okay. So we're going to take a look at if we just look at the range of motion test, 31, 32, and 33. We already did 31, and remember we found that her rectus femoris was in very bad shape. Remember we did that test, okay?
Yeah,
So
her-
sometimes called the Thomas test.
Yep.
And then we could do also the heel, get the leg off the side and do the heel to the buttocks and check it again that
Or
way.
lying on your stomach, you can
Or
do
we
that.
could lay it on our stomach and do it, and we could also do the lay on your back and do the heel to the buttocks test. So,
Okay.
so we can do. So we could add this here. We could do this one laying on our stomach next, and then we'll do this one to the heel to the seat.
And you could try it standing, make sure it's good standing
Oh, yes,
and
we could do it.
seated and
Go
everything.
ahead.
So
Let's try it standing.
let's just try standing. So this, in
Okay,
other
so-
words, this isn't hard to figure out. The rectus, you just got to get the heel to the buttocks.
Yes. Okay,
Okay.
so we're gonna get our heel to the buttocks here, and remember that this muscle causes really bad knee pain.
Oh yeah, let's look at the
Okay.
referred pain.
And
pattern.
thigh pain right here. So knee, really, really bad
Which
knee.
one?
This would be the rectus femoris,
Ah yeah.
attaching on the inferior iliac spine and then down to the kneecap.
Yeah.
Causes wicked, and this from way up here, from where you sit, where
Yeah.
you bend your leg,
Yeah.
where you sit constantly if you're doing Olympic sitting,
Yeah.
causes wicked knee pain.
Oh, yeah.
Okay, and then you're in danger of getting a knee operation. And here is our vastus intermedius, and then it causes pain in the whole thigh here.
Yeah, all the vastus muscles, you see, those quadriceps, they stay on the femur, and they cross over onto the tibia, but the rectus femoris actually
Passes
to
both of them.
It goes up there, so it actually can affect your SI joint and things too.
Right, so it crosses both joints.
Yeah.
Okay, so it crosses both joints, whereas the others do not.
Yeah.
So let's take a look at that one, and at the same time, we're going to take a look at the pectineus, and that one attaches right here onto our pelvis and then onto our femur here.
Is the pectineus an adductor like?
Yes,
also?
it's like the
an
fourth
adductor?
adductor.
It's like the fourth adductor. It's like
It's
the
the fourth
adductor.
adductor.
Why don't we call it just the adductor pectineus?
And of course, if you look here, it's L2
Same
to
nerves,
L4,
yeah,
L2 to
same
L4,
nerves.
and
Yeah.
to L4.
They're all-
Okay.
What was the vastus intermedius referred pain?
Oh, it's all over the front of the thigh. The front of the thigh,
Wow.
like a real big thigh pattern.
So-
But
and
it's
the
hard to
trigger point
get.
tends to be up here.
But it's yes, it is way up here, just the way the rectus femoris is way up there.
Okay,
So they're both way up high,
Uh-huh.
but we're still going to treat the whole muscle.
of course. And the origins and insertions, right?
That's right.
On the stretch, on the short.
That's it.
yeah.
Every other way.
And the nerve roots that feed
It's
the muscle,
everything.
right?
Everything. Yeah. Okay.
You guys are getting it, right?
Yeah. Okay, so let's take a look at these muscles.
All righty.
All right, so we're gonna measure a little bit. So let's have you,
On my back.
let's do on your back first.
So how would you do the quads on your back?
Well, I'm just gonna do the ones that don't cross the hip joint.
Okay, ones that don't cross the hip joint.
So here,
Do you need some water?
yes, I do. Okay, so if I could have, this is 5 inches heel to seat. I have some nice tea here.
Oh, yeah, it's a nice tea. All right, you're good. Sorry. Okay.
5 inches, right?
So
Let's
5
do
inches, the heel. And here, let's see.
So again, to the ischial tuberosity, so I feel the ischial tuberosity, and you're going to bring the heel just to where it stops, and then you go to right there and look, 5 inches. Oh,
5 inches.
excuse me, 6 inches.
6 inches, okay.
Put on my glasses. Let me look on this side again. Okay. Okay, so I'm going right to the ischial tuberosity. Okay, and over here, yeah, this one's 7 inches here. So
And you could also
have
do
my
it-
glasses on.
You could also do it lying on your stomach,
Okay,
you know,
yes,
and bring
that's
the,
a-
you know.
Okay, so next we're going to do it that way. Go ahead and lay in your tummy. Now this brings in the rectus femoris now.
Now, because the rectus femoris is with the knee straight,
Mhm.
with her knee bent, with the hip bent, I should say, it took out the rectus femoris. But now
Okay,
when you
so-
add the rectus
so here we're gonna,
femoris,
go from the ischial tuberosity to the, so here and just hold it there, and there we go. It's 6.5 inches
yeah,
left.
and that's significantly worse. So when you add the rectus femoris,
Mhm.
same with the test when she was on her Thomas test,
Yeah,
when she was,
6.5 inches.
yeah,
Okay,
you
so
can see, wow.
so we'll want to improve that.
Oh, yeah.
Okay, so let's see if we can treat it. We do something special. We're going to treat it on the stretch.
On the
okay?
stretch.
So we're going to come this way. So
Oh,
come all
how
the
are
way
we going
this
to do
way.
it? How are we going to do it?
Where am I coming?
You're coming all the way here. Keep coming.
Everybody understand that
Keep coming. Put
the
your feet right there.
rectus femoris crosses the hip joint, so you have to have the hip extended to test its length, and to test the vastus muscles. They don't cross the hip joint, so you flex the hip to test them.
Okay, so I'm going to have you scoot just a teensy bit further forward. Great. Okay, and then go ahead and lean back. Okay, so pretty comfortable?
Can I get something
A little bit
to
more?
elevate my
Could I have another, go ahead and sit up? Could I have another, I need more pillows. I got one, I
Grab
found
the
it.
face cradle.
No, this is, I got the pillow right here, I see where it is, I found
Okay.
it.
All right, that's good.
All right.
That's right.
I found it, so we got it. Great. Okay, so then I'm going to take the table up a little bit for the therapist. So I'm going to put I'm putting the rectus femoris on a really good stretch, and I'm going to go through the rectus femoris and treat the
Vastus
intermedius at the same time. So here I'm going to go to the inferior iliac spine. So I'm touching it right there. I'm right on the attachment.
Okay.
So I'm just feeling it there, and I'm right on it. I feel the muscle there. And remember, a lot of the trigger points are up high, way up here.
I feel that a little bit.
Not too much yet.
Now I'm gonna get to the intermedius almost right now.
I feel more.
Yeah.
I feel that.
Yeah.
Yes.
That's it.
Yes, I feel it.
So I'm gonna just touch first. Notice her breathing as she's exhaling. Then I'll probably be pressing in. So just the amount that she doesn't feel is too painful.
So we've got feet are up on a little stool here,
That's right.
so that the knees are
That might be
bent,
a little too much.
and the
Okay, go
patient
up slowly.
is
Okay.
reclined upwards
So I'm gonna come a little
on
bit. So I'm touching first. Touching. Now I'm gonna go
the
down.
body support system with some extra
Okay,
pillows.
okay.
Okay.
Come up slowly. So I'm right there. So I'm gonna use the other elbow and come down a little bit.
You're coming up slowly because you don't
You
want the
always-
muscle to contract again
That's right.
when you let go, right?
But everyone could try just coming up quickly and see how their patient likes it. Because if you come up quickly, then the patient doesn't
Then
like
they
it.
jump.
Yeah.
They feel jumpy. Yeah.
Okay.
So first I'm feeling. So right here I feel the resistance.
Mhm.
I'm gonna just go in a little bit.
This is like a 2-step stool that she's got so that she can be high enough so that her back is not bent too much.
That's right.
Now I feel it.
Patient positioning is really important. So yeah, so obviously regardless of where the trigger point research was done, they can be found anywhere along the muscle.
Well, yes.
Yeah, just because they show the X at one spot doesn't mean you ignore the rest of the muscle. And the origins insertions, right?
Well, you have to look at the fibers of the muscle. So let's take a look. Let's think about that for a second.
Yeah.
So let's look at the here's the muscle we're working on. So here's the intermedius, and you see the fibers mostly go up and down. So the trigger points for this one would tend to be, if you went in general, they would be more like about right here. But we still want to come down and treat all the tendon and the attachments there to the patella. So
where,
that's
where would
important.
the GTOs be? The Golgi tendon
Yeah,
organs would
it'd be right here, right here.
and right way up
Right
here.
there, right there, right there.
And where would be the spindle
This
cells?
would be the
Spindle cells there.
and you'd have all the neuromuscular junctures
Yeah,
would be
neuromuscular
in the
junctions would be
sensor
kind
here.
of all along, but a lot of them in the middle.
Yeah, it could be
exactly.
anywhere along, and probably all through there, in different spots.
The little spring spindle cell in the middle also determines the length of the muscle. So you have it's important to treat all these.
But here now you see these is more like a pinnate, and so look at all these different fibers that are there. So there's
Wow.
like lots of fibers, right? So then you could really have the trigger points could be, you could have taut bands and trigger points here, here, here. So the neuromuscular junctures could be all through here.
Yeah.
So that's why it's best if we treat the whole muscle. She finds that the referred pain comes mostly from there, but that's not true. That still we
Yeah.
have to have all these fibers working.
Yeah.
Okay.
Yep. We're looking for full function.
What do you mean when you're referring to the neuromuscular juncture?
The juncture in the center of the muscle where the nerve comes to the muscle to tell it to contract. So each little fibro comes to about five muscle fibers, and then it tells it to contract. So that's right in the center of the muscle.
Oh, okay. So like when you're referring to the belly of the muscle,
Yes.
that's
The
probably
belly.
where the
Yeah.
neuromuscular
Yes,
juncture
that's
is.
it. That's it. Yep, that's correct. Yep. Yes, ma'am. Okay, so we're coming down a little bit more medial here. And we're going to come a little bit all the way down to the kneecap, and I feel a lot of dysfunction here, lower part, right here.
It's not
But it doesn't hurt.
as painful as the other one.
Yeah, it doesn't hurt, but I can feel that that's good to treat here. Yeah, and you can see really it's a good area. Yeah.
I can feel it's tight, but it feels good to work it. Yeah, it's fine. Feels good.
Good. Okay, so we're putting it on a nice stretch, but we could keep treating it while we're stretching it, and some other ways too. But we could put it a little bit more acute stretch like this, So I might go ahead and put it just a little bit more in an acute stretch like that, and get it a little bit more stretched, and come and do it again.
Mm-hmm.
So this would be a good way, like that.
Yeah, I feel that more.
And remember, guys, muscles don't work alone. They have synergists, and
Sure
they have
do.
antagonists.
That's right.
So,
What if the hamstrings aren't working? They're going to have
Exactly.
trouble with the.
and that's exactly what we found. We found weakness in the hamstrings last week when we tested, and it was also coming from the nerve root. So hamstrings that are weak, it's like a seesaw. The antagonist is going to be tight. So these tightness of these quads could be due to the hamstrings being shut off because the nerve impingement in the lumbar spine.
Well,
See?
but we did find too that the hamstrings improved a lot by treating the quads.
Yeah,
Mhm.
exactly. So
So-
treat the whole unit.
Yeah.
Front and back.
Right. Exactly.
Flip her over like a pancake.
And I don't want to push you along too much, but we.
Okay, so keep it. So then we would go ahead and treat. So I'm going to have her do the self care on
Yeah,
the other one.
let's do
What do you
self-care
think
on
about
this
that?
side. Yeah,
All
please.
right.
Perfect.
Right. So if I could assist you with sitting up. And often, just tell me how's your back feel after laying on it that way?
Well, my back hurts sitting
A
up.
little bit. Okay. So a lot of times what you want to do after you've been laying, because we're not used to having our friends stretch that much.
Yes.
So the next thing you do is have them lean forward a little bit, and then you're going to go ahead and give them a little stretch. And then if you could have them stand up, and go ahead and stand up.
Well, and think about it too. What's happening? Why? If it hurts when you're sitting up, what muscle is supporting your spine as you sit up? Your abdominals.
Oh, you want me to lay down?
Just lean over for a minute.
When you sit up, your abdominals are bracing the spine. And so if you sit up and it hurts, then you should check for the function of the abdominals too.
But in addition, you're putting the paraspinals on the short.
Right.
And if you're giving them the opportunity to shorten up. So I realized that to stretch our front, at the abdominals or the quads like that, sometimes then you're shortening the back, so then we want to go back in and lengthen the back again.
So you just reverse it.
Yeah,
Like
just
a spoon.
reverse it. Yeah.
Yeah, there are always two ways to think about it. One muscle is being shortened, and then the other muscle is stretching. Likewise, you can think about what muscle is firing to promote that action. Sitting up requires abdominals and psoas. So that muscle, you want to test the strength when they're sitting. If they have pain on sitting up, you want to test those muscles. But what muscles stretching as you sit up? Well, then that's the paraspinals. So then you want to check the stretching
So I
of
was
those.
just testing the function.
Yeah.
And it was functioning really good.
Good. You're getting there.
Okay, so how's that feeling now?
So you were twisting her again, right?
Yeah, and also extending. So I extended and turned and twisted.
I felt the stretch in the hamstrings and the calves.
Oh, I was
doing that.
stretching then. Yes,
Yes.
that's right. Right, that's right. Okay, so we're going to show you how to treat your quad. Okay. So if you just go ahead and sit up here again, sit right there, and I'm going to put the stool here.
Yeah.
Okay, go ahead and sit there, right here. So this is a really good tool to use for treating. So you can go ahead
So
and
now I gotta get this way.
yeah. So do this one. Yes, go ahead.
All right.
Okay, and so this is the area she's treating here, and we have one way of treating it is using the foam roller and having it lengthened with using the stretching strap and then treating it laying on the floor.
Yeah, that's awesome.
That's a good way. So that's a really neat way. And here, these are the areas that we're going to treat right now.
Yeah.
Okay, so this is a good tool as well.
If you guys
So
like
let's
the
go
tiger
straight-
tails, those
Let's
work
go ahead and
good
use
too.
both hands and let's go straight down the center.
Mm-hmm.
Yeah. Remember how that was kind of tight there?
Yes.
So we're just holding it and using a lot of our arm weight. We're not using so much strength. We're just using our arm weight there. Remember, we want to get way high up here. And you're looking around for painful spots. And when you find a painful spot,
Oh, they're all painful.
she found the painful spot.
All of them.
And then you're going to get up a little higher and going to get right in there. Yep. Now so you could also use another tool as another good way of treating it. Sometimes you can use the back knobber, and you could use that. Go ahead and hold it, and then it gives you a little bit more leverage in here.
Mm-hmm. Oh
Yeah. It could come in there like that. And this is a nice tool. It's nice because you can see how you can
Just
put. Look at
lean
how
on it.
look at how she's putting her weight on it now. She doesn't have to use so much strength. So here, and then you could look around like that. Yeah, and just breathe and relax. And this works better for you, as I can see. Yeah. Yeah. So this works much better for her. Yeah. Okay, so then she could know. Now she wants to know whether she's doing a really good job. So she's going to test it now. So
Right.
you're going to. So we're going to see did she do a good job? Did I do a good job? And so did we improve it a little bit?
Yeah.
So we're going to see did we improve it? So we'll test it next. Good. Oh, I like how she uses this.
Yeah. She's liking this.
She's really good at this.
Yeah.
Look at how she's doing it. She gets, see how she's
Gotta
putting,
use leverage.
look how she's putting her weight in there. Yeah, that's
Yeah.
really great.
Yeah, definitely.
Yeah, she's doing it really good. So I think she's gonna fix this.
Let's see.
Give
All
it a
right,
shot.
so let's go ahead and have you lay down on your tummy again.
Or she was on her back.
Well, well, I would like her to lay on her tummy,
Oh,
even if she wasn't laying on it before. Again.
yeah.
I was just thinking.
Oh, okay.
All right, so here we're gonna have you test. You're gonna grab a hold of it. Okay, so you're gonna see. Ooh, look at that.
Wow.
It comes really close.
Nice improvement.
Okay, so that's nice.
Like
so that's
3 or 4
pretty
inches?
exciting.
Oh, yeah.
One more time. Okay, so there. So we're gonna see that it's about 2 inches now. 3. Okay, now resist and push away. Push, 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 push.
I have to use this hand.
Okay, that'd be fine. Yeah, great. And now bring it towards your seat. Okay, now 2.5. Okay, push away. 2. Now push away. 2. About 2. Okay, let's try it on the other side.
Great. Nice improvement. Way to
What was
go.
it, 7 or something before?
Yeah.
Yeah, it was pretty far
5
before.
and 7.
Yeah.
Different times. And 6.5 at another point. This was 6.5 in this position. Okay, so is that good with that hand?
Yeah. The other
Okay, so
one, the
we'll
integral.
start with about 3.5 inches. Okay, go up, resist and push away, and then relax, and resist and push away, and then relax. Good. And so we're getting down to 2.
Great.
Yeah, little
Getting
less
lots
than
of
2.
hearts.
Okay,
Camille, getting lots of hearts.
Thank you.
Well done.
Okay, so as a therapist, this is what I would do also. So I might have them do it as we're doing, but also I would be holding it in different positions. Have resist and push away, and relax, and resist, and push away, and resist. And then also, I would probably treat the hamstrings
Yeah.
to make sure that I got them to be able to contract more.
Short.
Shorten more.
Yeah.
Yes, correct. Shorten more.
Sometimes she switches contract and shorten around.
Yes.
She does
Sorry.
that.
Shorten. Okay, so you did good. You did good.
Yeah.
All right, so that
If you want to roll on your back and try that on your back to see if it was better.
Oh yes, but you can also test.
Yeah. Well, let's.
For strength?
Oops, you got to turn her off.
Oh.
This way. Remember, so we did this too. Originally, we had her like this, right?
Yeah, you're
We
measuring
test,
that
yeah.
way.
Yeah. Go ahead.
Okay, so go ahead.
Yeah. So yeah, definitely got some improvement there, and their side. Oh yeah, definitely. Wow. Yeah. Even much closer than it used to be.
So this
All right.
would be, this is the part that's more closer to the knee, and this part here improved more.
Okay, so
Okay,
the
go
rectus femoris crosses the hip and the knee, right?
That's right.
So to test the rectus femoris, you bring this up to 90 and 90, hip 90, knee 90. Hold this right there. Now, I want you to push into my hand with your knee. Go ahead and push. Then I'm going to add 1, 2, 3, 4. Good. Okay, that was strong. And I'll go into this side. So there's rectus femoris. I have to get the knee and the hip in this test because it crosses both joints. So push up into my hand. Now I'm going to add 1, 2, 3, 4. Okay. Each one is about, 1 unit of extra resistance. Okay. Now to do just the vastus, I will use this just for
We'll do
support.
the same. We can
And
do.
I'm
okay,
going
yeah.
to put my hand like this.
Mm-hmm.
Okay. So that I'm kind of in the fossa of her knee in the back.
Yes.
Then you just push up into my hand, and I add 1, 2, 3, 4. Okay. Try again. Keep pushing. 1, 2, 3. Okay. We're having a problem with that one. Yeah. It's not. So go ahead and push up. Push up. Up,
So for the-
up, and
the-
1, 2.
So for the intermediates, it's still got trouble.
Yeah, and
Yep.
I can test the more medialis vastus medialis, right?
Medialis.
And
mhm.
push up into my hand.
More medial. Mhm.
1, 2, 3. Okay, so the medial is all right. How about the lateral? Push up. 1, 2, 3. Okay, but just the intermedius. Push up. 1, 2. Okay.
Intermedius
So
doesn't like you.
intermedius does not like to
And the-
contract.
Yeah. So and the traversus intermedius is the hardest one.
Yeah, here, keep it tilted that way.
Oh,
further.
okay,
Otherwise
good.
I'll have to rotate
Oh,
it.
that's bad. We don't want to do that. Sorry.
Okay, let's try this again. So straight up, push into my hand. 1, 2, 3, 4. Okay, this side seemed to have gotten better. Okay. We need more treatment on that side, okay?
Right.
Let's try vastus medialis. Push up. 1, 2, 3. Oh, good. And lateralis. Push up. 1, 2, 3. Good. Okay. So, out of all the quadriceps, the only one that tested weak with the strength test is the vastus intermedius.
So we want to keep treating that till it's
Right,
it's-
because we spent more time on this leg, so.
Yeah, well, yeah, Sharon spent more time on this, and you didn't really get to this part
Right,
as
I
much.
didn't get to that.
That's
yeah,
true. You see?
see,
So,
see.
That's it. we didn't get to that yet.
okay, good. All right, what do we got next? We got 15 minutes. We better
We're
run.
gonna do the QL.
Are we going to do the
Cow.
sartorius and pectineus?
Oh, well, let's do that. Let's do the sartorius and pectineus. Okay,
Okay.
so here's the sartorius. It starts here and ends here at the pes anserinus.
It's the lap muscle. When you put your up into a, that,
Like
that's shortening.
That's its shortener.
Sartorius is now straight in a line.
Mm-hmm.
Boom, 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 boom. And then as you take it out, it
And this
twists
way,
around.
this is its stretch.
And that's its stretch. Yes, now it's twisted around like
That's
this.
its stretch.
Like
So like this, so bringing it up like this, so you bring it up yourself. So bring it up like that, that's its contraction.
Yep.
Take it out towards me, that's its stretch.
Yep.
Okay. So so we're going to treat it while we're stretching it. What do you think of
I
that?
think that's great.
Yeah. So it's right here, so to here, so we're going to do its stretch.
How about a picture of it? And,
Oh, let's look at a picture.
Yeah, let's
Yes,
look at a
right
picture
here.
of it.
Let's
It's
get
a
it right
really
here.
long muscle. I can't remember, but it's like one of the longer
Well,
muscles
no,
of the
it's
body.
the longest muscle.
Oh, it is the longest. Okay, I thought it was something
Isn't
like
that
that.
the Taylor's muscle?
It is.
Okay,
Yeah, Taylor's
I
muscle.
remember that.
Yes, it is.
The lap muscle.
They would sit cross-legged.
Yes, it is the longest muscle. Very long and thin, like a little snake that wraps around from the ASIS down around the knee to the pes
Here it is.
anserinus.
Here it is. Okay, here's the sartorius.
There it is.
And then here is its referred pain pattern. So up high, it causes it to be more painful higher, mid pain, and then as it comes down. But it also could cause really bad,
Wicked medial knee pain.
really bad.
Oh,
yeah,
wicked medial
tendinitis
knee
right
pain.
there.
Yeah, yeah.
The really bad tendinitis.
And it's one of the
there.
muscles that you need to treat this origin insertion. That origin insertion point is so important.
So we'll do that.
Yep.
And again, this one was one that could cause this cutaneous
Oh, yeah,
femoral
it could
nerve
pinch
compression
that
because it
nerve.
actually could go through. The nerve could actually go through the muscle.
Wow.
Right there, or underneath it, but it often could go that way. So we're going to treat that next. Okay, so here it is.
Yeah, tiny little long muscle. Thin,
Yes,
long muscle.
yes, here it is. Here's
Probably
our
the
one.
left one's worse, so if you want to treat
Oh,
that one.
okay, do that one first. Okay.
Yeah, get the left one first.
right.
Needs more
The
treatment.
patient is requesting.
So there's no
Yeah.
great range of motion tests
This is more
other than
injured.
can they make a lap, and then Sharon, she's just doing it by hand. The way
Well,
Sharon,
really, I do have a measurement. It
Okay.
should go to about, it'd be great to go to 90 degrees that way. It may be about a little bit more to like 45 this way.
Okay.
So this would be nice. So,
Okay.
but we're going to see what improvement we can get by treating it. So here we're going to go, here's its attachment at the pes anserinus. And then we're going to see what part makes it move better. So I'm right on it.
And that's the same as treatment.
This is treatment.
This is treatment.
Uh-huh.
So it's evaluating and treating through the full range of motion.
Yeah. Okay, so I'm just going to hold it a special way here.
Yeah, the first two spots were really.
Yeah,
the worst
down by the knee.
ones, Yeah.
And let's look here. Right there.
That's a
Okay,
one,
good.
too.
So let's take a look at the range of motion again. Can you bring your ankle inward towards Justin? Good, and relax. And bring it inward towards Justin. Okay. Bring it outward towards me and relax. And towards me and relax. Okay.
Okay, and then quickly, want to see the strength test on this one?
Let's do it.
All right, hold that sideways there. So, yeah, we just bring it into this position right here. This one's kind of tricky, but I have my hand cupping the ankle here and my hand on top of the knee like this. And basically all I'm doing is pulling it out of its lap position. I'm undoing her lap. She's doing her lap, I'm undoing her lap. Okay? So go ahead and pull up into a lap position, and then I will add 1, 2, go ahead, pull. 1, 2, 3. Okay, so I'm holding both at this point and this point at the same time. That seems fine. And same here. I'm holding here, here. Go ahead and pull up into a lap, and I'm going to pull down 1, 2, 3, and both seem fine. Okay?
Great.
Okay. How about gracilis? I'll do mine
Gracilis.
first.
Oh, no, we're not doing gracilis, but
I'm sorry. What are we doing?
Pectineus?
Pectineus.
Oh, okay. Pectineus.
Pectineus.
Pectineus is the same test as the adductors, folks.
Okay,
It's the same
yeah,
one. So
okay.
I don't have anything to show you there.
okay.
Yeah, same as the adductors. Yeah, yeah.
Okay, so we'll show pectineus
Okay.
pain pattern.
Yep.
Okay,
Pain
so
pattern.
we'll do pectineus here. So let's see if we can find it.
It's adductor number 4.
Oh yeah, that's it. Where the other.
Very, very, very
Oh, no,
advanced
it's not.
kinesiologists do differentiate between them, but it's so silly. It's like wiggling this toe and doing it and wiggling that toe. It's not necessary.
Okay, here's the pectineus.
Yeah.
And here causes pretty bad pain right here.
Yeah.
In the groin.
Right.
And here it's attaching onto the pelvis here at the superior ramus and then onto the femur.
Yep. Exactly.
Okay, so let's take a look at it. What's the range of motion test for that one?
Is there one for pectineus?
Yeah.
It's number 43.
small.
It's the same as the adductors. It's just the same as the adductors. It's the same lap test. Yeah.
Okay, so I like to treat this in full range. So here's his attachment onto the femur.
Yeah.
Here's his attachment over here into the pelvis. So I'm right on it. You can feel it doesn't want to do anything.
No,
Okay.
that's
It doesn't want to contract here. Okay. Yeah. Okay, so it's a pretty painful one. Let's take a look at it a little bit more without moving it. So since it's so painful, I'm gonna treat it just so I'm gonna feel the superior ramus there, on the pelvis. So I'm just gonna touch it lightly. You tell me what you think.
that's okay now.
And then we're gonna come a little closer to the femur.
So you find this is a common and important muscle to treat?
I don't treat this as much as I treat the psoas.
Yeah, that's my opinion too.
I don't treat it as much as I do the quads.
And as you're covering the entire psoas, you get around to its attachment there. You kind of hit those points anyway, I think, in general. But hey, if it's the cause, it's the cause.
So then we're going to cut both, especially if he has that pain pattern right there. So that's often how you
Right.
get it, is
Yeah.
you see that pain pattern.
Yeah, if you got a pain pattern right up in the crease of the hip there, then you think,
Then you can put your
could be
finger,
that.
you can put your finger right on it. You see, does it contract? Does it stretch?
Wow, that's too much there.
Wow, something is really
That's
going.
painful there. Yeah.
Yeah, it's very painful.
Push away from me. And relax.
Do you think that is the
Push away.
pectineus indeed
Oh,
that's
that's
causing
pectineus. Yeah.
that? Wow, so she has a bad pectineus.
Push.
And this is the one that can cause the pelvic floor trouble.
Not so much, but
No.
some pelvic. It's the ones with the adductors. Yeah.
The ones we already did.
And and the iliopsoas. So I'm using the opposite muscle and just touching it lightly and using the opposite. So painful.
Why
would
would
you-
this be so painful?
Oh well, why? She had just had a car accident.
And banged my knees into the dashboard.
Yeah. Okay. Now it's working. Okay.
Yeah, well,
That's
it's
not
much better.
painful.
Look at
So
that.
not so painful now.
Wow,
Okay.
great.
So that's good. So that's our pectineus. And how would she treat it?
How would she treat that and the sartorius?
So she could, one way of treating it is not bending. You could do it this way. You could actually hold on to it and press right there on the pelvis. See what you think. Do you think you could do it that way? Yeah, like that.
I'm not sure that I'm.
Yeah,
getting
you're
it.
right on it. So
Am I on
so
it?
right here. Okay, right there. Then you're gonna come right here. Yeah. So it's too hard for your arms to reach.
Yeah.
Yeah. So let's try it this way.
Okay, try it.
So then I would do it like this. I like to reach in like this. Yeah, just like that. Just like that.
Yeah, that gets it.
Wow, that is one for you. She's got a
Right there.
a pectineus.
I've got a
folks. She's got
pectineus.
one.
Okay, and then you could press there, and then lift it slightly, and then go down and see how it works. See if you're
Oh, yeah.
see if you're that's it.
That
yeah.
gets it.
Wow, great, great,
That's your little pectineus.
great. See, I was going to discredit this muscle, but no, I can't do that.
Okay, so
Can't
let's
do
do one
that.
more thing. Let's have you stand up, and then we're gonna do it. I'll do it together with you. You hold this one, and I'll hold another one.
There's one right there, yeah.
Okay, so we're going to take a look at our pectineus. So let's put one foot on our little stool here. Okay, so we're going to take the pectineus right here, press on it, and then we're going to take the leg back and stretch it. So take it, we're going to shorten it, press right onto it there, take it back like that.
Okay. I'll move this table for you.
That's good enough.
I think I'm getting it now.
So look right onto the pelvis, right there on its attachment onto the pelvis. And when you shorten, you can get in there a little better in a way. And then like this, then you're sort of like, yeah. Well, she's doing it. She's doing it.
Wow.
She's on it.
I knew this would be a good one for you.
Thank you.
I had no idea. Wow. All right.
Okay, we did it.
Great. And sartorius, pretty easy, right? You would just have them follow the sartorius along the points.
Yeah, so if you could go, let's go ahead and let's do the sartorius. We could come like here, so we're going to go right here and
I wanna
get the
do this one.
attachment.
There's
Do
that
that one.
I'll do this.
So we'll do right where it attaches onto the tibia here,
Oh.
the lower leg. Look for a painful spot there, and then come on up. And we're going to come, it's kind of a beeline from here all the way to the superior iliac spine. So we're going to come like that, coming through here. So we're come over here. And then look for a painful spot here. And look for
So
a
on,
painful
so
spot
forth.
here.
All right, we got 5 minutes for the QO. We better get going.
And here.
Mhm.
And then come a little higher up.
Last muscle.
Okay, the last muscle.
QL.
Okay, so we'll do the self-care first.
Okay, self-care first. 'Cause I really want her to do this. Oh,
Okay.
before we do anything, can we do the tests?
Let's do the
Just
test first.
Do the side bend QL
Let's do
test.
the side bend QL test first, okay?
Measure how far your
Okay,
fingers
so
get from the floor,
yes.
right?
Okay, so here we're gonna do. Okay,
Should I bring my arm
so
over
what
or
you
not?
want, no, not arm
No.
over, but remember you want your shoulders to
Oh,
be
shoulders back?
and then you're gonna just go sideways and just inch down. Look up at the ceiling a little bit. Yeah.
There we go.
Okay,
Measure.
So good. So then that's 18.5 inches.
And try the other side. QL is so likely to have one side different than the other. So likely for one
And
side.
this is 18.5.
Those are, okay. Now, for the strength test.
Strength test.
This is an important strength test, people.
Here we go.
This is one of the important ones. Lie on your back, facing up. So get the table to a good height so you don't hurt your back. But what you're going to do is you're going to brace this hip right on this side, and you're going to slip your hand underneath like this, and you're going to cup both their legs like this, so your hand is on the outside of the ankle. Then you're going to move this toward that side, because that's the QL contracting, that side. So I'm testing this side. Now I'm going to ask her, keep your legs off to Sharon, okay? So go ahead and push your legs towards Sharon, and I'm going to pull back towards me. 1, 2,
Yeah, right.
Go ahead and pull. 1, 2, nothing.
None of that.
Okay. How important is the QL in making sure that you don't have nerve compression?
Very important.
Oh, it's extremely important
yeah.
because most compression comes from vertebrae being twisted this way or twisted that way, right?
Right.
Okay, so that's how you really, those vertebral foramen, when they bend, that's what crimps down. Okay? So same thing, I'll have her bring her legs to the left. Now she could already swing them, so I'm imagining this side might be strong. You keep your legs toward the window, push to the window, and I'm going to push 1, 2, 3, 4. Oh, okay.
That side's stronger.
Right, and the other side, she couldn't even
So-
get to 1 pretty much.
Couldn't get anywhere.
Should we treat that side?
Yeah, we should treat
Let's
it.
treat the weak side.
This is
Okay.
the weak side.
Yes.
Let's do it. So,
It could cause nerve compression on either side, though. Okay?
okay, so let's have
The-
you sit up for a second so we can put the body position. Okay.
Okay.
We're going to treat the QL in that side.
Sideline.
Yes.
Okay. Then I have to face that one.
Well, you're going to treat the weak side or the strong
This
side?
side.
This.
Oh, yeah, the weak side is one I would treat.
All right, treat the weak side.
I mean, you could treat them both, obviously, but likely the weak side.
Okay. Okay, let's have this arm this way and this one here. So
And while
this,
she's
can I
doing
have
that,
this leg here?
Right here.
let's talk about why it would be weak. Here's another one of Sharon's famous postures.
So here.
You see this
here's our
posture?
here's our attachment right here and here. And she even I just touched it like so light that you can't believe how light I touched it.
Yes, I know, and I felt it.
So what that means is the nerve there is screaming to the spine saying, ouch, don't fire, we've got a problem. And that's why Sharon's going to teach that nerve that it doesn't need to be that
It doesn't need to be so upset.
Yeah, it doesn't need to be upset. That's right.
So it's hypersensitive.
Yeah, oh, it's totally hypersensitive. It's screaming bloody murder, and that's why she can't fire the
And it
muscle.
tickles too.
Yeah. So let's talk for a second about
yeah.
why do trigger points cause weakness in muscles?
Wow.
Because they, if there is a painful bundle of muscle, it's going to hurt when it contracts. So the body shuts that part of the muscle off.
Well, how about if the attachment is painful?
Oh, and the attachment is painful, then the
Then it shuts
GTO is just to shut the whole
shuts
thing
the
off.
whole thing off.
Yep.
Well, how about if it's already completely contracted? Can it contract?
No, not anymore, right?
No. So all those things could make it appear to be weak.
Yes.
Plus the nerve roots causing hypertension.
Yeah. So you can get a football player, you can get the best gymnast, best in shape person in the world, and if they have trigger points, those muscles will be weak.
Exactly.
Right there's a good spot. That's tight.
So we're right on it there. Yeah.
Yeah, keep it low, people.
Good. You can
Yeah,
do
you
it.
can put it.
I put a really super long one right there. So can you undo it? It's designed for him to use for this purpose. The other one, the one that's right there.
Unravel that.
Yeah.
Sorry, I'm gonna have to switch to another power cord here.
Yeah.
Great, thank you, Sharon. Good. Great. Super duper. All right.
Now I got a
perfect.
super long one.
Yeah, good job. There, much better. Okay, guys, I was losing power. So, I had so much anticipation wanting to get to this muscle because she's having this severe nerve issue, compressing all those nerve roots, whether it's the skin rolling test or, well, okay, this is a quadratus lumborum. Let's talk about the nerves. It's all along the entire spine. We didn't show a picture of it.
Oh, let's do it. Let's do it. Linda,
It's
you
T-
can help us. You can find us. Here's the
It's
book. You can find it there.
T12 all the way down through L3. So let's quadratus lumborum. Let's see. Here it is, quadratus lumborum. This one right here.
I think page 30 or
See? So it receives nerve innervation from T12, L1, 2, and 3 mostly. Those are the ones that textbooks say. So that's where it receives its innervation. And if it's cramping down on one side, if it's weak on one side, like this is her spine, weak on this side, not on that side, then it's going to be pulling this way. It's going to be causing cramping down of the nerves. And it could actually be either side, but that could cause weakness of any of the muscles in the lower extremities that are fed by those nerves. Okay, and we found the skin rolling proved that. We found that weakness of several lower extremity muscles. You guys remember what they were? Last week, hamstrings and glutes. We didn't test those this time. This week, what lower extremity muscles did we find that were weak? We had two quadricep muscles on both sides.
The intermedius.
Yep, intermedius. And then what was the big one?
Which other one was weak?
It wasn't the adductors.
It was the psoas.
It was the psoas. Yes,
Yeah,
it was the
it was
psoas.
psoas.
Yes,
Yeah, it was
yes,
the
that's
psoas,
it.
yeah. Okay, so here I'm treating it while I'm shortening it. So I'm bringing the hip and the ribs closer together.
Yep.
And then I'm taking it further apart. And,
Yep.
and then pushing it closer
Yep.
together. Take it further apart.
So the
I'm
origin
extending
insertion
it.
points are along these ribs. It'll be real tender along the underside of the 12th rib and on the crest of the ilium there. This is so important to treat those too.
So the QL is like this shape. It's more like this. So when I was treating like this, and then I'm also treating shortening it and lengthening it. Yeah.
Yep.
Okay, so it's
Did you
looking
guys
better.
get that? She's going down, but she's also coming down and from the back and down and from the front.
Now, a lot of times people are treating the iliopsoas from here, and really that's
You mean
not.
the QL?
I meant to say the
Yeah.
QL from here, and it's here. You're not really getting it from the back. You
Yeah.
actually need to get it from the side.
Yeah. Although you can get some origin insertion points that way. You can get some of those from the back. But yeah,
It's tight in the back, though. I could feel that.
Yeah.
yeah.
So it also does extending. So I'm going to take it and do it. Do an extension
Uh-huh.
because it does extending.
Yeah.
So I'm getting right into it there.
So what might we anticipate improvement in? Well, we'll want the QL to test strong.
Yep, we were looking for that.
Yep, we'll want
The psoas to be strong.
possibly the psoas to suddenly be strong.
Mm-hmm.
And I doubt that's going to change the issue with the knee, the vastus intermedius. I think that's something more local. But yeah, that would be the big thing. And we didn't test them today, but last week the hamstrings
Bring
and
your knee forward.
the glutes were weak.
And relax. Come forward. Good. Okay, so let's see what we can. Let's do our test.
Well, can we show our self-care for one quick
yes,
second?
let's do
What
it.
kind of
Let's do it.
self-care would
Let's
we
do
do?
it. Okay, let's see what have you had. Go ahead and sit up and then stand up.
Oh, I'm sorry. I'll hold this. You do self-care.
Oh, okay. All right. Okay, so one thing that you could do is use your tool on your waist on the paper, the side
On
we
this
treated.
side?
Either side, yeah. So, but we got to get right on so you got to get it on the same side then, because it won't.
Oh, yeah.
So you got to get it right here.
Okay, but we're working
Yeah,
this
let's
side.
do that side then.
This
Yeah,
is the side.
yeah.
Okay.
Okay, so we're gonna get it right on the side, right there. Yeah.
Right on this.
Yeah, and now let's do it together. So let's contract our hip and let's stretch it. So let's go side, side, like that.
Yeah, exactly.
You could get right on it. You could go ahead, stretch it, get right on it like that. So go, yep, like that, yeah, or contract it. Yeah, oh, really good. Super great. Yeah.
Stretch and contract.
And get a little further back.
And of course, you would, it's always good to treat both sides, of course, but
Now, another really good way to treat it would be to, look for a second. You could get on your side and lay sideways. Put your tool here. And really treat it sideways like this. And take your time and get right on it like that. So you can do it laying down too. Okay, so
all right, good. Well, we didn't. Let's just see how much did we get any kind of a change.
okay, let's do it.
Should we do it? Okay. So review our 2 strength tests.
Yeah.
So here we go. So you bring her legs off to that. Oh, she moved all by herself.
She did.
I can tell that. Well, I didn't do anything. Now you hold toward that file cabinet, toward Linda and Sharon, and I'm going to pull toward me. Okay, 1, 2, 3. All right, good.
All right.
Yeah. And let's just see, without affecting the psoas, without necessarily knee straight. Remember the psoas?
We're gonna take it.
It goes and hooks around. So I'm bring it till it's straight like this. Okay. Push up into my hand. 1, 2, 3. Oh, you see that? Very good, very good.
All right.
And oh, she's moving it all on her own. I know it's going to be strong when she lifts it like that. Push up. 1, 2, 3. Good. And we could even do the skin roll test and see if we haven't affected some of the nerve roots.
Okay, we can do it.
Should we do it? We'll have Sharon do the skin rolling and see.
Do you want me to stand
Yes,
or lay down?
we'll stand
Stand
for
for
that.
that
Yeah, because we want to see.
This part was worse when she was
When
standing.
you were standing, we'll just see. Okay, so let's tuck it. We'll tuck it.
Tuck that up. So you can
We'll
breathe.
tuck it. Okay. All right, good. So here, so don't lean forward. So yeah, okay, yeah. So there we go. So here, skin rolling's pretty good.
It's getting better, is it? Not
Yeah,
better?
it's pretty good. Yeah, it's pretty good. I got one spot here.
That spot is
Yeah,
still, you can see it.
Uh-huh.
Yeah.
Okay, so good on this side.
Yep.
So we have one more spot
Yeah,
right here
it
that we
needs
might
more.
want to get in,
Yeah.
and we could let's just one little special.
That's the
thing.
same side as the bad QL too,
yeah.
right?
Yeah.
So
that
we'll
was
just
the
so
QL.
if I could just do one little special thing for you, if you just come back over here with me.
And we didn't thoroughly,
And
that's,
we're gonna have you come
yeah.
like this.
Okay.
we didn't thoroughly work on the muscle even, and we got those good results.
We did,
You see,
yeah.
you know?
So give me your whole thigh.
She actually
Here.
needs to spend more time on that
Lift your
QL.
whole
Lift it up.
Your whole yeah. That's
Oh,
it. Yeah.
okay.
Yeah, and then you get really close to the edge. Yeah. Super. Okay, we're stretching it. We're stretching it.
Okay, Sharon's
Ah.
Sharon's Sharon's got her on the stretcher.
So, oh.
Look at that stretch.
Yeah.
See? Sometimes you need to take the muscle beyond where it thinks it can go and just show them that it's okay, guys. You can do this. And that's what Sharon's doing. Sharon's going for the good stuff. There it is.
There, it's stretched.
That's it. That's it. That's the point where it surrenders. Sharon says, no, you can do this. And it goes, no, I can't, no, I can't. And then it goes, oh, I guess I will. If will you stop pushing on me if I do it?
Okay, let's give it a try. Let's have you stand up.
All right.
And let's have you stand with your back, with your thighs facing this way. Okay, and we're going to just have you just stay right there.
Oh,
Yeah.
just straight.
Pretty good.
Getting better.
It's getting better. So this is our goal, is to get really, so this lifts up really good.
Yep.
So but there's more to be done.
Yep. But if we had to diagnose it, we would say the QL on the left side
Yes.
was filled with trigger points and it could not contract, which was causing little muscles in the spine to have to take on the QL's job, which was causing cramping down of the nerve roots. So little rotatories and multifida are having to do the QL's job, and they're cramping down on nerve roots, which is causing inhibition of QL of the iliopsoas, and last week the hamstrings and glutes, which is causing a whole bunch of problems.
Mm-hmm. And relax. Push right here. And relax. And push.
Let me show that. Let me show that.
And push.
She's just doing counter strain here
And push.
on the opposite
And push.
shoulder.
Okay. So I'm just saying, now we're doing better. Come over, take a look. So,
Doing better, doing better?
so we're doing better. Mhm.
See, Sharon's going to get it. That's her thing. Class is over, Sharon. Class is over.
Okay.
Sharon is yet to be defeated by a trigger point. Okay, everybody, thank you. No time for the song. We'll get it next time. See you all next week. All right, bye, everybody.